Good morning, ladies and gentlemen.
Good morning.
Okay, you can hear me. Thank you. Okay, just checking. Okay, so good morning, ladies and gentlemen, children, and welcome to the 10th Annual GTBank Autism Conference. I believe that 10 years doing anything means a lot to anybody. And we're very glad that as an organization, that this is our 10th year advocating for autism with the objective of representing the views and rights of children and adults living with autism and making sure that they have their say and get the support they need to thrive. My name is Oyede Adegite. I work out of Communication External Affairs at Guarantee Trust Bank, and I'm very happy to welcome you to the 10th Annual GTBank Autism Conference. Because we know that advocacy begins at home, we'd like to say a very big thank you to parents for sharing the diagnosis of your children and obviously giving us more information that is more factual, that obviously dispels myths and misconceptions. And so thank you to parents, to caregivers, to guardians, to all practitioners, professionals, as well as educators. We say a very big thank you as well. It is everything that we all do collectively that brings about the change that we need to see and that we all want to see, and gives the children and adults that we hope to support a place in the world. And that is something that we believe everybody deserves. And so thank you for attending this conference. We hope that over the next 2 days that you would find the conference very educative, very informative, and we hope that you would have discussions and interactions that can bring about the right interventions in whatever it is area that you're looking for. And so we've shared the conference program. We hope everyone has received it. We'll go through this for 2 days. We'll have the conference for 2 days. The first day would have six keynotes, six keynote addresses, or maybe I would say six facilitators who will touch on different topics relating to autism. And tomorrow would have panel discussions, would have question and answers. So any questions we're not able to take today, please give us till tomorrow. You would have enough time to put your questions forward and hopefully get the right answers. What we hope for is that you get the right intervention in any area that you're looking for over the next 2 days. So I would like to move on very quickly to introduce the Chief Executive Director, Chief Executive Officer of Guarantee Trust Bank, Mr. Segun Agbaje, who would give us the keynote address for today's conference. This program is a program he's very passionate about. As an organization, we're all very passionate about this. And would like to say a very big thank you for his support over the years, which has helped us be very consistent in all our programs and to ensure that we do the right things in implementing our programs. So a very warm welcome for Mr. Segun Agbaje. Thank you.
Thank you. Good morning, everybody. Thank you so much for joining. I don't know how many people we have on the call, but I'll try and be very brief. I'm sure it's not me you want to speak to or listen to. I'm sure you'd like to listen to the people who are experts on this matter. One thing I'd like to say is that this is something that's very dear to our hearts. The whole autism thing we do is really precious. Everything, we do about 4 events a year, I think, and 4 major events, and we cancelled everyone but this one. We didn't have the heart or the willingness to cancel our autism conference. That's how important it is to us. We started this journey about 10 years ago. I believe this is the 10th one. And when we started, all we really have always wanted to do, and I'm not sure it's changed much, is basically just take baby steps. First of all, get people to understand what autism is all about and people who live with the condition. And then having done that, we can then try to educate ourselves and the people who care to be a part of this to be able to deal with it in a more normal way. And that's kind of what we decided 10 years ago. My personal journey was a very funny one. When we started autism, I always used to think about it as something that only had to do with children. And in my learnings, I realized as we went up through the years that people who are children living with autism become adults living with autism. And then that brought its own different challenges on how to deal with it. And so now again, I think we're transiting into something else. Every year we've tried to get people who are experts at this topic. Um, Hopefully it's drawn out parents, relatives who have either children or adults living with autism and made them more comfortable about sharing their stories and their experiences. I have met parents who I didn't even know had children living with autism, and we've had good engagements. We've gone outside of Lagos, we went to Abeokuta, and the response was again shocking. We had people who had never even brought the children out before and brought them out. And so, like I said, our baby steps are working. We have people who are experts in this field who kind of educate both you and I. This year, they've come up with something again. I have to remind myself of the topic. I think it's focusing on similarities instead of differences. Again, they tried to take me through all the very technical parts of this, but I'm not very good at dealing with the technical and medical part. And so I, in my own way, try to understand what the themes or what the topics are. For me, living with similarities was a very simple thing. And I kind of looked at my life and I said, well, you know, in my life, there are days when I'm sad, there are days when I'm angry, there are days when I cry, there are days when I yell, there are days when I feel like holding someone's hands, and there are days when you want someone to give you a hug because you're just not feeling that great about life. And for me, those are emotions that whether you are me or you're living with any condition, whether autism, those are emotions that we all go through. And for me, at a very basic level, those are the similarities that I see. Nothing too technical, just regular day-to-day emotions. So that when you're dealing with people either with autism or any other condition and you see that, please remember that it doesn't make them any different from you, it doesn't make them any different from me. We're just all expressing ourselves in different ways. And so even though we have all these differences, I think we have so many similarities that are just our normal, raw, natural emotions which we go through. It's a 2-day conference. I hope you'll stay with us. I hope you'll ask all the questions. It's obviously very different. This is the first time we're doing it on a virtual platform. We've all always been in a hall and had a chance to learn. But, you know, until we get back to where we can all very safely cohabitate and have large functions, we thought it was important we do this. So at this point, I'd like to just allow the experts to take over. And I wish you, for those who would be kind enough and patient enough to spend the next 2 days with us, I hope you will learn something. I hope I will. I hope I'll take some more baby steps towards understanding people who live with this very special and very unique condition and has created very special and very unique human beings. Please enjoy the rest of your 2 days and God bless.
Thank you, sir. Thank you very much. Thank you, Mr. Agbaje. So that was the CEO of Guarantee Trust Bank, just taking us, sharing and talking about the theme for this year. And so without any much ado, we're going to go into the session proper. And we have our first speaker for today, Dr. Andy Shih, who will be taking us through creating a community of support for people living with autism. Thank you very much and welcome, Dr. Andy, your stage. Thank you.
Thank you very much. It's really a pleasure to be here. I feel honored to join this conference today on this 10th anniversary to share some information about what Autism Speaks and our team at Public Health Department do in particular. I also want to just echo what Mr. Agbaje mentioned in his opening remark about how it is so important for us to focus on things that we share within the community rather than differences, because once we recognize what we share, there's opportunity for us to move forward as a community. Of course, the important thing about and understanding our similarities in spite of the differences is information. The stories that we hear from families, the story that we hear from policymakers and professionals are important in helping us understand not only what's happening with our families now, but also what we can do together, building on our shared challenges to make a future a brighter one for all of us. So I'd like to start my presentation by just giving now. So today, even though the talk title is really about how to build a inclusive community, as I said in my introduction, for me, the important one of the first important step in doing so is to have information, is to hear our stories, is to have that understanding about what the lives of individuals and families affected by autism is like. And so to that, I'd like to really talk about how our organization and Autism Speaks in particular is trying in recent year trying to make a difference for our families globally by fighting against inequity across the world. So hopefully in the next 20 minutes or so, I'll give you a sense of our approaches and outcomes of our work that we've been doing for the past 10 years. And an example of our current international priority, which is in the form of a work report that we're working on right now with WHO and UNICEF. And then also an example of our current domestic priority in the United States, where we're trying to better understand the needs of our family, to gather information, as I mentioned to you, so we can build on our shared challenges and needs. So over the past 10 years, starting over 10 years now, we've been working globally with our partners and family. And we've been doing so through a signature initiative called Global Autism Public Health Initiative. And what we do is that we serve as technical advisors to committed government ministries and NGO partners, typically Ministry of Health and so on. But we also work with large national NGOs and sometimes parent groups and so on. And we started this initiative with 2 countries in 2009, Ireland and Albania, but now we're in over 80 countries around the world. And what we do is that we put our expertise and our support, process expertise behind the local leadership, and to source the right expertise so that we can start to identify not only challenges, but solutions that can make a difference for our lives going forward. And a lot of this work is really driven by our partners, our collaborators, and these are individuals like all of you, family members, policymakers, professionals, local leaders who have had a record of innovation, of facilitating change. And these are self-advocates, caregivers, researchers, professional policymakers, and they're all friends, and many of them are family members. And we are interacting continuously on social media, and we have biannual meetings to facilitate knowledge exchange and transfer collaboration. And this has been going on for over 10 years now, and we have come together and collaborate on many high impact work, including you'll hear later from my colleague, Dr. Dixon, the Caregiver Skill Training Project, as well as the World Health Assembly and UN resolutions. We're currently in, actually this is a little dated, in 2018, we have 54 countries, over 60 countries now, and we're gradually transitioning to regional sustainability, which I will tell you about next. Okay. So as I mentioned, we have this regional network meeting every other year to bring people together. And about 2 years ago, we started transitioning to the more regional meeting because the size of the network has grown so large. And I'm very happy to share with you that this past January, we had our first regional meeting for Sub-Saharan Africa in Addis Ababa in Ethiopia, and we have almost 24 countries represented, as well as representatives from WHO and UNICEF present. And these are some of the pictures. You may be familiar with some of the advocates shown in this picture, including Dr. Nwanzi, Mr. Nwanzi from Nigeria. So our work really is focused on equity, as I mentioned earlier. So and I want to make sure that we're on the same page when we talk about this issue. There's a big difference, between equality and equity. I think some people, even policymakers, often have it confused. Equality is when you give everybody the same thing, regardless of need. But equity is really taking the need into consideration. And this is important for us because, as you know, individuals with family affected by autism, they need things that are more than what is normally available in education, in health, in social welfare and protection. So the idea of focusing on what can we do to support a family based on the needs is central to everything that we do as an organization. And our approach really is driven by data, right? It is really important for us to know the information, to understand what is happening on the ground at all different levels of the community that could in fact impact the life of our families. So we see ourselves in this really sitting in the intersection between community, policymakers, and researchers. And our priorities is project development, implement community-based services and solutions that focus on equity. And we bring the strategy we bring to the table is really one of collaboration. We work with stakeholders such as yourself to produce knowledge together that will inform solutions and answers. And then we also help you to understand, are we really making progress? Again, by looking at data, measuring the steps that we're taking, as the president of GTBank mentioned in his opening remark. So some examples of the work product that we have produced, including screening diagnostic instruments, interventions that you hear about later from my colleague, new policies and economic tools and service navigations and so on and so forth. So the Advocacy Leadership Network, which we work through, really have accomplished a lot of important deliverable for our global community. And I listed a few in this particular slide. So we were, very much involved at the United Nations with let's say the Qatar and the Republic of Bangladesh in advancing several resolutions related to autism that really provide legal framework for our global community in order to advocate and to act. We were the technical advisors for many country governments, including South Korea, Mexico, India, and more recently Qatar and China, to really produce a first national prevalence estimate. How many people are affected in your country? And actually, we have done a little bit of work in Nigeria as well. National action plans. We have been participating, providing technical support for national action plan and training programs found in Qatar, Albania, Bangladesh, and so on. We produce an important economic analysis study, really looking at what the cost of autism is. What that means is what is the average cost, at least in the U.S. and U.K., to support an individual on the spectrum for the lifetime. We also are very much into supporting research innovation. So, for example, we support the first randomized control trial using what we call the task shifting strategy for low resource community. Again, you'll hear about this from my colleague, Dr. Dixon, in her presentation, which is the Caregiver skill training program, the first WHO UNICEF intervention package that uses particular strategy to deliver evidence-based autism intervention in low resource community. So now let me go down a little deeper into our international priority. So I'm really excited to share with you that right now, Autism Speaks, World Health Organization, UNICEF, are working together on a world report on developmental delay, disorder, and disabilities. And this report is really a global partnership, right, by the three organizations. It's the first report of its kind. It prioritizes conditions that are not well covered elsewhere, including autism, ADHD, intellectual disability, because we know that conditions such as hearing and visual are important, developmental condition are well covered elsewhere. But things like autism is really not found and well covered in any other kind of an international reference guide, in providing guidance for government and profession, but in terms of what to do. We do take a lifespan perspective, as Mr. Agbaje mentioned in his opening remark. It is a lifelong condition, and even though we know a lot more about early childhood and what to do, how to best support them, our family need to have solutions across the lifespan. And this report really target ministries in health education, policymakers, advocates, and so on. So it's a tool for all of you to use in order to better understand how can you make a difference in your community. So it highlights opportunities for multi-sectorial collaboration, coordination, and acting early, and so on and so forth. And most importantly, and this is not found in any other global report to date from WHO, is really the proactive inclusion of user perspectives. What that means is that we are actively collecting information from families like yourself, right, about what your needs are all over the world, so that we can better inform our recommendation to the policymakers and the professional. Now, this draft is due because of COVID. There's been a delay, but we're also using this opportunity to look at COVID and how it exposes existing inequities, right? And how it helps us better understand what the needs are, the real gaps are, so that we're collecting additional information, and we're delaying the publication of this report till early next year at this point. But we hope that the report will increase awareness and public health significance of this condition. Will provide a kind of benchmark on data about human resources, epidemiology, and services. We'll provide some guidance to country governments and stakeholders and activists about how to strengthen health systems and sectorial action, so that we can enhance provisions and support for our family in all settings. We want to document good evidence-based innovative practices, and want to provide guidance for collecting data, right? We need to continue to have information about our community in order so we can better understand the unmet needs, as well as whether or not we are really making a difference with the solution we're introducing to the community. And then we are using this tool to really call our partners international and the national level to work together so that we can deliver a better future for our families. Here's a basic outline of the reports, the introduction, epidemiology, all the basic section that I mentioned earlier, from care pathways to public health monitoring. And we will highlight good practices and innovations in this report. And most importantly, we'll create what is called a country profile. And this is basically what we call a country report card, which has the basic information about the country, demographic and so on, as well as indicators that will suggest, that will provide information that the country or the nation is actually making progress in the community. So this become a powerful tool for advocates to use to encourage more progress and more proactive action by policymakers. And you can see that we really have a benefit from a worldwide cast of participants, including, of course, Dr. Bolajanko from Nigeria here, and we're having additional expert joining us as well to look at the report. So, and obviously I look forward to sharing all of that with you when it's become available later this year. You'll be, I'll be free for all from the World WHO, UNICEF website, as well as Autism Speaks website. Now, let me turn my attention for the remaining time into something that's related, but is really focused on the U.S. But I hope is that when I talk about this particular issue, and you'll see it has global implications as well. So in the U.S., we have a lot of issues, even though there are, I think there's a general belief that we have answer to a lot of challenges, even though in some areas we do have, better support, better services. We have many challenges remain, especially in minority community, in low resource community, in poor families, for example, or family living in rural areas that are more difficult to reach, and so on. So many of the challenges that we have in the US are very similar to what we see in low and middle income countries abroad. And so because of that, we really have the same issue, right? Information. What do we know about our community so that we can tell our story and use these stories to leverage for change? And so the really fundamental question that we ask ourselves is, where is the data? Where are the basic information that are important for policy development, implementation, and evaluation about our family? And these include, who are the users? Who are the people that are using the service or not able to get to the services? Where do they live? What are their needs? What are the services that are provided where they live? And what are the challenges in meeting those needs? And finally, and just as important, what is the outcome when you have benefit from those services? Are those services actually doing some good for your family? But these are basic information that are really important for all of us to better understand, how to better support our family. But unfortunately, the information is not already available, because oftentimes what you see is that the health ministry has some information, the education ministry has some information, and so on. In the US, is certainly very fragmented. And so, but you can actually reach out and try to grab these administrative data, right, from health ministry and education ministry to get some understanding. However, even when you do that, the information you're still missing is really information from the users, information from the family, right? That at the end of the day, to us, is the most important thing. Because if the families are not benefiting from the policy and the program that you're putting into the community, then we must do something to change that, right? Then something's not working. There are barriers, there are other processes, there are other factors at play that are preventing the best outcomes for our children and our families. So really trying to understand not only what information is out there in the community, that in the hands of the government, but also the needs of the family is very, very important. So Autism Speaks developed a tool we call the Public Health, the Family Needs Assessment Survey. And this is really a tool intended to give the families a voice all over the world. Okay. And so just briefly, a little bit about this tool. It's a family needs assessment survey that is a revised version of a tool that's been actually been piloted earlier. We've done this pilot and it's been published the information as well in 5 countries in Southeast Europe, and then in 6 countries. And we actually published this paper just last week for Latin American countries. And what we did thousands of families, right? And hear from them in terms of what their needs are. And this tool is aligned with existing standardized instruments and tool. So there's opportunity to put these data into larger context when you think about policy, and it's also modular. So if, for example, in some area, some country, there's more interest in stigma, so actually we can actually add a module that really allows to better understand challenges related to stigma in a particular area. So this tool is really designed to be translated, adapted, and so it can enhance the user quality data, and it can be implemented in different settings, in different community settings. And this is really what the tool helps us understand. I know this is a really busy slide, but I want you to focus on the center 3 rectangles: the needs of autistic child, the daily challenges of the caregivers, and the caregiver's perceived quality of life. What we're saying with this particular tool is that those 3 things, the way we measure them is to understand the conditions of the child, the demographic characteristic, family education, so on, the stigma, the perceived disability, and the access to services, access to treatment, knowledge, and so on and so forth. All these factors come into play to really, at the end of the day, give the family a sense of the needs and what they have that are meeting their needs, and what they still need to have in order for those needs to be met. So this tool really helps us collect data and organize in a way that is that's really just stories really from the family, but you organize the data in a way that is meaningful and accessible to researchers and policymakers. And because of that, what we're doing now is that we took this tool, we had piloted the online version of this tool earlier this year. We have adapted for collection of user data in Argentina, Brazil, Bulgaria, Canada, China, Turkey, and very soon in Uganda to inform the world report I mentioned to you just a few minutes ago. So as you can see, what we're doing is you take a tool to give the community, give our family a voice worldwide, and take that information in and making available to the policymaker and the stakeholder worldwide so that we all have the same information. We all understand what our common challenges are, in spite of the regional variations, right? What the common challenges are, what the possible solutions are to the unmet needs that we face as a global community. And that we hope that when this report is published, later next year, the information about the family really will elevate this report so that there's a better sense in terms of what we need to do that will translate into immediate impact in terms of well-being and outcomes of our families worldwide. And with that, I thank you for your attention. I just want to remind you that autistic people and their family really are at the heart of everything that we do. Thank you. And do I have time for questions? Okay. I'm looking at the question.
Dr. Andy, you do have time for questions, so you can take a few questions. We have another 10 minutes, so please go ahead.
Okay, very good. So the one question is, so here's a question about a individual Zimbabwean who's living in South Africa and who's interested in helping out raising awareness. So we are actually working with a various stakeholders in South Africa, not in Zimbabwe, unfortunately, but in South Africa. We're working with Autism South Africa, for instance. We're also working with researchers in Stellenbosch University, as well as University of Cape Town. We also have a relationship with the community and researchers in University of Durban. So you can certainly follow up with me privately. If you're interested, I can connect you with these individuals. We have another question about how we design the Family Needs Assessment Survey to capture the needs of Nigeria so we can reflect the positive significant changes within our policy here. That is an excellent question. And we'll be happy to work with you, to think about how we can potentially implement this the survey so we can have more information about our families in Nigeria. We're working with some excellent clinicians and research in Nigeria already. Then, for instance, Dr. Mudin Bakare in Lagos, and also Dr. Olayinka in Ibadan University, as well as many others. So we, please follow up with me via email. We can happy to work with you to see we can implement this Family Needs Assessment Survey in Nigeria. Let me see. Yeah, great question about what. There's a lot of question about Autism Speaks presence in Nigeria. So I will I'll answer all three of them right now about our plan in Nigeria. We work with, in addition to the researcher I mentioned, Dr. Olayinka and Dr. Mudin. We also work with the IP Foundation in Abuja, that's headed by Mr. Nwanzi, and so we've been trying to implement various programs in Nigeria with the Nigerian community, and of course it's been a little more challenging than we had expected. But we are continuing our work, even though obviously COVID has slowed things down a little bit for us. We continue to work with our various stakeholders, and I think the opportunity over implementing a family needs survey is certainly there, and possibly even some kind of intervention program that my colleague will talk about later on. Okay, let's see. Yeah, so autism training. Here's a question about professional training and certification if you're autism in Nigeria elsewhere. There are these, university courses, for example, that I think my other panelists will maybe be able to provide better information about opportunity in Sub-Saharan Africa, particularly Nigeria. But I know that there are, training opportunity both in Sub-Saharan Africa as well as abroad, and a long-line format where you can learn more about how to serve our families. There is no current presence Autism Speaks Nigeria. We work out of our New York office mainly, and what we do, as I mentioned in my presentation, is support local leadership and local leaders such as yourself. Okay. So yeah, I'm really glad there's a lot of questions about the caregiver needs survey, family needs survey. Again, this is something that we can be translated, adapted, and we are be happy to work with you to do that, member of the community. Okay, so the question about Kenya. Yes, we are also working with collaborators in Kenya. We're working with Society of Kenya, of course, and as well as the Wellcome Trust Center in Kilifi, Aga Khan University in Nairobi. We have colleagues there as well working with in Kenya. Yes, so it's just a question about working on validating screening tools and ASD and IDs in adolescents. Absolutely. We're actually supporting a research project right now in Sub-Saharan Africa, bringing together researchers from Kenya, Malawi, and South Africa to look at the issue of, can we develop more efficient screening diagnostic instrument for autism in this community. Our challenge community data collection autistic people doing research, right? So the question is, what are the challenges in community data collection of autistic people doing your research? So like everything else, it's about communication, right? You want to make sure that they understand that the purpose of collection is at the end of the day to benefit the community, to benefit individuals like them. And also, and this is much more difficult, is to find ways in which the data that you collected can be returned back to the stakeholders, can be used by the stakeholders to advance their interests, their priority, right? So I think these are the real practical as well as conceptual challenge in terms of data collection for autistic people in the community. I'd be happy to answer more questions too. Yes, so again, be more than happy to, there's a lot of interest in terms of making connections here in Nigeria. I'll be happy to do that. Yes, I can give you my email address. Just type it. Okay. Do you see the impact or influence of faith in needs assessment? A really interesting question. I'm not sure exactly what you mean. Are you suggesting that do we cover faith as one of the needs in the assessment? We do, not in depth, but that's just is an opportunity I think we can look at. For example, if you want to develop a faith-related module for this needs assessment, that's certainly something we can do. In the U.S., for instance, there's really a lot of growing interest to include our children and family in faith-based activities, right? Because unfortunately, in many places of worship, at least in the United States, our children and family are still excluded. So there is a lot of interest to do more about this. Okay. So are there grants for researchers for autism, especially for young researcher? there are. Both Autism Speaks and our sister organizations, Autism Science Foundation and Simons Foundation, they all do offer different grants for researchers. Again, you can reach out to me. I'll be happy to send you the link. Okay. I don't know if I still have more time for answers or.
You have exactly 3 minutes, so you can take a few more questions.
Okay.
And if there are any questions left, then they're just going to be rolled over to tomorrow, and then we can answer them tomorrow. So we're going to try and answer as many questions as possible between today and tomorrow. So yeah.
Okay.
So please go ahead.
All right.
2 more minutes.
All right. So maybe I'll focus in my last remaining minute on just one question here. It's great. It's just talk a little bit more equality versus equity, right? Can you just talk a little bit more on that regarding autism? So within autism community, there's 2 equity-related issues that we're really focusing on. One has to do with severity or level of impact, and of course, in the U.S., it has to do with race. Let me just talk about the severity, the level of impact. We all know that individuals affected by autism, they're all affected differently. Some are more severely affected with intellectual disability and other physical clinical issues, whereas others have no intellectual disability, but obviously certainly have social communication challenges. So when we talk about supporting and providing service for these individuals, I think the notion of equity is important, because what you don't want to do is because it's not a one-size-fits-all question, right? It's not. We know that in autism, no one solution is appropriate for everybody, and what we've been trying to do as a community in over the year, in trying to better understand how to really provide solutions and answers that best meet the individual's needs, and I think that's really the heart of the equity challenge, is that for those individuals who are more severely affected, who, for example, who couldn't feed themselves or who have other clinical challenges, epilepsy and so on and so forth, well, they need a little bit more attention, right? They need more care. So when you dole out support and services, individuals who have greater needs should receive more care. That's really the fundamentals about this. And of course, expanding this to a broader lens in the U.S., when you have racial element at play as well, then what that means, as well as poverty and so on, what that means is that the solution you provide really should pay extra attention. And it's not just about autism. It's also about how to really help individuals so that they can have the same access to the services, so that money is not an issue, right? So that where they live is not an issue in terms of their ability to access quality services. So this is what I'm talking about in terms of try to think about solutions that are more equity focused rather than equality focused.
Okay, thank you so much, Dr. Andy Shih. That was an amazing session, but we have to now move on to our next keynote speaker, Dr. Pamela Dixon, who will be speaking on implementing training in the home post-COVID-19. Thank you, everybody, for joining. Dr. Dixon, over to you.
Yes, greetings, everyone. Many thanks to GTBank for your long-standing commitment to the autism community. I was particularly touched by the CEO's description of this cause and this conference as precious. So I appreciate the spirit of that. I also want to congratulate those who worked so hard to pull this conference together, the organizers, and I look forward to these 2 days, exchanging ideas and knowledge and experiences with everyone. So I have been asked to present on the Caregiver Skills Training Program as a method of implementing training in the home post-COVID-19. There are some common experiences of parents who have children with disabilities, and over the years, it's been my honor to sit down with parents from across the world who have given me, who've shared some of their experiences and given me permission to share them with you. And so there are some common experiences I just wanted to walk through with quotes from actual caregivers. So denial is a common experience. So for example, mom said his father would say, that's not my son. In our family, we don't give birth to children like that. Another common experience that caregivers feel is guilt. So this caregiver said, well, we got married and we were expectant, and this is the baby we got. And sometimes I regret, and I ask myself whether I did something wrong. So parents often blaming themselves. Disappointment is also a common experience of parents. So this dad said, they say I got an epileptic child and I'll never benefit from her, meaning that his daughter would not be able to take care of him in his older age. Fear is also a common experience. So, a caregiver said, I didn't understand all of that because I was so scared. And they were referring to the whole process of going to the doctor and, and trying to get screened and then diagnosed. And of course, stigma is there, and it's something that has a powerful effect on families. So this mom said that someone in her neighborhood used to say, they used to shout at her son and call him a name, do not play with my children, because that person was afraid that playing with her children would result in them having the same condition. And then, of course, religious beliefs are a tremendous source of support, but can also provide some challenges. So this caregiver said, I still go to the pastors, even if I do bring my son to the hospital, and they tell me he has demons. And then, another person said, my husband's relatives have said a lot. They say I did something and I should know the cause of my son's problem. So if these experiences of parents are part of what we are hoping to address in our caregiver skills training program. I wanted to start with just some history of how it was developed. Dr. Shih talked earlier about the World Health Assembly resolutions that Autism Speaks has been instrumental in promoting. And so in 2013, the World Health Assembly adopted the Comprehensive Mental Health Action Plan. And what's important about this is that the vision of the plan was that was a world in which mental health is valued and promoted, and where people who have mental health disorders are able to experience a full range of human rights and access to services as everybody else. Which goes right along with our theme for the conference. There was particular emphasis on the need for there to be high quality, culturally appropriate care that's delivered in a timely way. So this is part of the history that's leading up to the development of the Caregiver Skills Training Program. Similarly, there was a resolution on comprehensive and coordinated efforts for the management of autism spectrum disorder, which particularly called for the reduction or elimination of institutionalized care. And so if you're, for communities to then be able to take care of their people with disabilities within community with autism, there would need to be some attention on giving some training for caregivers and how to do so. The World Health Organization also has a program called the MHGAP, the Mental Health Gap Action Program. The emphasis here is on scaling up care for mental, neurological, and substance use disorders, and developmental disabilities is considered a priority disorder. And really the focus here is on providing an integrated set of integrated packages that are evidence-based. Researchers, the World Health Organization pulled together researchers to just scour the literature to collect all the data that was available on what are the evidence-based practices and interventions. And it promotes a life course approach and really focuses on empowerment of users and families. Again, part of the environment that helps to lead up to Caregiver Skills Training Program, and you'll see that the Caregiver Skills Training Program fits within MHGAP. There's an intervention guide that was developed that, and this is a picture of the cover of the guide, so that providers and communities, even where they didn't have specialists in mental, neurological, and substance use disorders, could get training in how to manage these conditions. So within the guide, there are recommendations for what to do when you're faced with specific conditions. So for example, this is another picture of the guide. Underneath the category of developmental delay or disorder, if the provider, physician, nurse is presented with a child who has a developmental delay or disorder, one of the recommendations you can see is that the provider should offer parent skills training when it's available. So the need for parent skills training was very evident because it was recognized that this is something that's evidence-based, meaning that this leads to change in children and helps promote their development. So thus now we have the Caregiver Skills Training Program was developed to address the need for caregivers. So there are field trials and implementation sites in 30 countries, and we have within the continent sites in Kenya, Ethiopia, Zambia, Egypt, South Africa, and Uganda quickly approaching. And there are, some of these sites are randomized controlled trials, meaning they're very rigorously done research sites, and others are implementation sites where the sites are taking this on with the intention of determining if this is feasible within their location. The target population for the Caregiver Skills Training Program is caregivers, meaning parents or other family members of children who are 2 to 9 years of age who have a developmental delay or developmental disorder or concern for one. A diagnosis is not required because the intention is not to contribute to stigma by requiring a diagnosis in order to participate. And we recognize also that many caregivers many communities have struggled to be able to provide diagnostic services. And this age range is also slightly adapted in settings. And families find the program either because they have heard about it and refer themselves, or their primary health care providers or community health workers or specialists make a recommendation for them to participate. Some of the characteristics of the program are that it can be delivered by non-specialists, and this helps to build capacity. So training is provided to non-specialists who can then help, continue to grow and help others. And it can be adapted for use in low resource settings. It was developed to be so. And it's effective because it's based on evidence-based practices, which we'll talk about, and it's currently being rigorously studied in several sites. It should be freely available. And the goal here is for it to be integrated into existing systems of care. And so as a WHO program, the intention is for it to live within an existing system, such as a Ministry of Health or Education or Social Services, so that it can be formally adopted by a higher organization that will be responsible for making sure that this becomes part of services that are regularly available to families. The program is delivered in 9 group sessions, and they can take place, in person at health facilities and at the community level, in schools, and they usually take 2 to 2.5 hours. They're usually done weekly or bi-weekly, and we've recently started doing groups via telehealth as a result of the pandemic. There are also 3 individual sessions in caregivers' homes that are held at the beginning, towards the middle, and at the end. And the purpose of those individual sessions is to individualize the program, because the group sessions, there's a lot of discussion, there's homework for caregivers to do throughout the weeks, and then there's an exchange of ideas and support, but the individualization of the program happens during those home visits. And we've also started doing those home visits remotely through telehealth as well. The program, as I mentioned, is based on evidence-based practices. So behavioral approaches for promoting shared engagement and communication, which are the primary areas of focus for the program. Specifically, 2 approaches within behavioral intervention: JASPER, which is a joint attention, symbolic play, engagement regulation, which has a very strong evidence base, as well as PRT, or pivotal response treatment or training. It also draws from aspects of applied behavior analysis, including DTT, which is a method of structured teaching in small steps. There's a strong focus on positive parenting in the curriculum, and for helping caregivers with skills to manage challenging behavior. The material also helps caregivers do some problem solving and promotes their well-being, the importance of their well-being as well. So this gives us more information about what the content of the 9 sessions is. So as I mentioned, there are 3 home visits at the beginning, the middle, and the end. The foundation, the first 2 sessions are focused on helping caregivers understand the importance of and how to engage children, with the idea that if you can get them and keep them engaged, then you will have more opportunities for learning. The child will have more opportunities for learning. So caregivers are given practical strategies for how to do all of these things. And the next session focuses on play and home routines. Specifically, how do you use things that you're already doing with with your child, whether it's games that you're already playing with them or games that you could play with them, or home routines like bathing, like eating, like cleaning. How do you engage them in those types of activities in a way that promotes their social engagement and promotes their communication? So there are specific strategies that caregivers are given in the program to help them with their children. And then when they come to the sessions, they discuss what they've tried, and then they have homework that they are given to help to practice throughout the week, and then they come back and talk about it. The 4th and 5th sessions are focused on communication, both understanding when a child is communicating, what that looks like, and how to promote communication. The 6th and 7th sessions are focused specifically on challenging behavior, both understanding it and then what do you do about it. The 7th, the remaining sessions are focused on building skills, and specifically daily living skills. And then the final session is focused on caregiver well-being and problem solving, though caregiver well-being is discussed in every session, and is how each session begins with taking caregivers through relaxation exercises, and then helping them to problem solve throughout the sessions, ways that they can make sure that they're able to come to sessions and do the homework that's suggested throughout the weeks. So what we expect after a caregiver participates in the program, we expect that that there will be some progress on the goals that they set for their child during the home visits. The leader, facilitator, or master trainer helps them set goals that are realistic to be achieved within those 9 sessions. And then they are monitoring over the sessions to see if they are making progress. And so there's an expectation that there will be progress. and that the child's going to increase their social engagement, their ability to attend to an adult and an activity, and also that their communication will improve, and that any kind of behaviors that challenge will be reduced. There's also the expectation that there's going to be improved caregiver well-being and improved family functioning, and we have clear data from our research sites to support this. This program is very well received by families, and they experience improved psychological functioning and feelings of empowerment as a result of participating. And we also expect, and we're also seeing, that the program contributes to reducing stigma in communities. You know, some of the families that participate in the program were keeping their children indoors. And so their community members may not, or maybe just suspected that there was a child that was somewhat different living there, but just coming out and going to the sessions was a way to raise awareness within communities and help to deal with stigma. So I wanted to show just what some of the session booklets look like. They're all illustrated. When a site a country decides to adopt the program, then the first thing that's done is that the materials are translated and adapted to be culturally appropriate. So this is just an example of what a session with some of the materials look like. There's a set of materials for the caregiver, hard copy, and a new set that are electronic, as well as a set of materials for the person who's leading the groups. So this is, all the materials are set up, and the key concepts are described in terms of key messages and tips. So this is just an example of a key message that children communicate using words, behavior without words, and challenging behavior. So this comes from one of the communication sessions. And so you can see how it's illustrated and was developed to be able to be used in groups of caregivers who have lower literacy. So we are often asked, well, how do people get trained to do this program? So we've given here an example of what the training structure looks like. There are trainers that are sent, part of the World Health Organization and Autism Speaks, who come to sites and do trainings of master trainers and supervisors. So these are the people within country who are going to be responsible for training others and supervising others once those people are independent. So they train a group of master trainers who then train a group of facilitators. And facilitators are the people who do the actual groups with the caregivers, these small groups. And we have some suggested criteria for who a master trainer might be. Here we're looking for specialists, meaning that they have had some clinical experience working with children with developmental disorders, and that they have educational requirements. That their education includes formal training in child development or mental health. And perhaps also the exposure to the image gap.
Dr. Dixon, we're going to have to round up in about a minute. I'm so sorry.
That's okay. I'm coming
if
to
you just round up in, yes,
awesome. Yeah, thank you.
You're welcome.
Facilitators are the people who do the groups with the caregivers, and we want them to have some experience working with children with developmental disorders. So I'm going to I'll fast forward to the end because I want to make sure that you're aware that we have, as part of the toolkit for implementing the program, there's a new e-learning version that is available currently online. And if you're interested in if you're a caregiver and you're interested in previewing this program before it's released, to give us some feedback about it, I would encourage you to reach out to me, and I can send you a link to the program online so that you can see it with a little brief survey. We are keen to release it in the fall officially so that caregivers who don't have access to groups can access it to do it in a self-paced kind of way. So I have included my email address, and I will be on a session tomorrow to answer any questions that I'm not that are presented today that I wasn't able to get to.
Thank you so much, Dr. Pamela Dixon. I can very rightly say that everyone enjoyed that session. I can see it in the comment sections. They want to try it, they want the link, wonderful presentation. So thank you so much. I just want to remind everybody that you should put your questions in the Q&A tab and leave the comment section strictly for telling us, where you're coming from, what country you're watching us from, what you do, and that sort of stuff. And then leave that, don't put questions there, put the questions in the question and answer tab strictly, because that's where all the keynote speakers will be looking. And if you want your questions answered today or tomorrow, you better put it over there. Okay, so we're going to be moving on to our next keynote speaker, Dr. Loretta Burns, who is going to be talking about reimagining learning spaces for children with special needs. She's the founder CEO of Advanced Behavior and Educational Clinics in the United States. I'm personally very excited to listen to what she has to say. Dr. Loretta Burns, I'm going to hand over to you as soon as you come on. Awesome. Thank you so much. So handing over to you now.
Thank you. Thank you for having me here today. I am always excited the annual conferences that GTBank puts on. Last year was amazing, and I really do want to take my hat off and say, despite the pandemic, you pulled it together again to support families and support clinicians, and really again continue to promote the wellness and the resources to support this family and this field. Thank you, and thank you for having me. So my focus today, and let me share my screen with you. My focus today will be on reimagining special education students and their needs. Okay, so let's share the screen with you. So reimagining learning spaces for children with special needs. Although with this pandemic, one thing that we really need to look at is how do we continue to support families, students, clinicians? How do we support those within this field? How do we support children with autism? How do we support individuals with autism? Although you are now faced with the challenges of no longer being able to attend schools, attend clinics, and attend physical environments to continue having your needs met. So as clinicians and as educators, we must help our parents grasp and understand virtual learning. My focus today is really going to be on understanding what to do next. And I know often when I provide presentations or training within the clinics, within schools, it's always with the concept of practicality. How practical can we be with our services? How practical can we be so that we make sure we are delivering the right programs, delivering the right resources, so that every family feel that their needs are being met, and above all, every individual with autism's needs are being met. And really, in my focus as a cognitive disorder specialist, really that work within mental health, the work with individuals with autism, the work with individuals with intellectual disabilities, it really is to continue to work so that we see progress, continue making sure that day by day that we are delivering the best supports, evidence-based practices that can better the lives of those who require the additional supports. So unfortunately, this pandemic has hit us all globally. However, it doesn't mean that life should stop. We really want to encourage, and I want to encourage our schools, our facilities, our resources, as everybody is slowly shifting into virtual therapy, teletherapy, and the likes of within this platform, to continue delivering those services and to continue providing supports. What does that mean for our parents? For our parents, it means fully understanding what virtual learning means. For our families, it means understanding when people use the terminology distance learning, what does that really mean? How can my child who requires to be in a setting with clinicians and teachers and other students or other individuals to interact and socialize, what does distance learning look like? So really, when we're looking at this, let's look at parents. You will need to become the new special education trainer. You will need to become that new learning coach in your home. You are your child's number one advocate, as I always share, and you know your child better than anyone else, no matter the age, whether they are toddlers, whether they are in middle school, elementary, high school, or whether they're now living independently or still at home, you still know your child better than anyone else. With your understanding of your child will help you support setting up these learning environments in your home. You understanding their needs better than any clinician or educator will allow you to create the environment that you will need to set your child up for success. Let this be your primary tool for success. And now to the clinicians, when you're working with families, this is a new approach for those that haven't utilized teletherapy services in the past. This is a new approach for those who haven't utilized virtual supports previously. Families are trying to wrap their heads around how to have their children's needs met. So clinicians, and when I speak of clinicians, whether you are a psychologist, whether you are a behaviorist, whether you are an occupational therapist, a speech pathologist, and so on and so forth, really think about how can we continue educating families, educating parents to understand what do I do now and how do I do it? So consider adding additional supports in all of your related service areas. So for example, if you have 30 minutes of speech, in my clinic, we've moved our 30 minutes of speech to 45 minutes or an hour. That additional time allows to set your family up visually. It allows time to get the student ready, get them prepared, set them up online, let the parent ask questions, make sure that they're in an environment where they can be in a distraction-free space in order to make the most of your session and that you can continue your supports. Reduce distractions, providing students or providing your child parents with headphones in the home when they are in a virtual session online. Providing those headphones, noise cancellation headsets can really allow your child to separate what's happening in the home and focusing with a session that's being currently set up for them. Above all, and I cannot stress this enough, provide visual schedules or visual aids. This will help each of your clients, parents, this will help your children. This will really help with the virtual aspect of what it now needs to be, considering we're removing or the physical aspect has been removed. By providing visual schedules and visual aids, you will have that cognitive connection. There is that connection where we're not just speaking at you consistently, but there's that visual support that ties into what the brain is trying to neurologically connect with the words that are being shared. Ensure the use of positive behavior interventions that is easily implemented by parents. So clinicians, this is a time to really step back and think of practicality. When we speak of positive connections, when we speak of token economy systems, how can we train parents to implement those consistently during a virtual session? How can we train parents to understand this is when you use this and this is when you need to refrain, and this is how we continue dealing with behaviors as well as making sure that our sessions are beneficial, are positive, are impactful, and that we're continuing to focus on goals. Remember to also provide frequent breaks. A lot of the students who are moving from physical settings into virtual sessions are really still now trying to learn and understand, how long do I sit in front of the screen for? When do I need to leave, or when do I get up and take a break? And also, please take the time, especially now that we are in a virtual platform, to train both the parents and train each student with their assistive technology. Training on iPads, training on using the laptops, training on how to utilize the mouse, how to use your camera, are all imperative items of training. As we try to transition to virtual sessions, please remember to gather and review data. Data is still important. We know that we develop our goals based on assessments, based on data, and our data drives those goals. So we can further measure and monitor the goals that we are hoping to meet, and for every student to meet those goals. How can you get the student to attend each session regularly? Utilize data to understand what those social emotional needs could be in order to be able to implement those sessions. How can you closely monitor progress on goals? Have those goals been defined? Have they been readjusted? When we sit in IEPs now, and as I continue to work with families and people within the schools and clinicians, really let's maintain our support of the IEP. You shouldn't at this stage throw that IEP out the window. It should still drive what is being planned for that student, drive that educational plan. How can we present it now with fidelity in this virtual setting? Does a student exhibit maladaptive behaviors during sessions? And if the answer is yes, how can we implement new interventions behaviorally and practically that the student can continue to learn and the parent can continue to support? Make sure that you are now collecting data more frequently, and I would suggest 4 to 6 weeks. Despite the data you collect after each session, every 4 to 6 weeks, realign, assign, review. Does my 6-week data show that I need to tweak something in my virtual service and my virtual support? Schools, as I mentioned earlier, consider maintaining these IEPs. I know many places are now closed. I would urge and encourage school principals, head of schools, to find ways to continue to reach out to your families, reach out to the students, and continue the IEPs. We don't know when this pandemic will end, but we know education is vital. We know it is imperative and must continue. So what we are here to do is help to support you in delivering these virtual services. If you need the support, reach out and we can guide you and support setting those up. Review progress on goals. Discuss the data taken during each virtual session. Review new accommodations and supports. Does your child need frequent breaks? Do we need fidget spinners? Do we need bouncy balls? What can be done to be able to provide these additional supports in the home, in the setting? Be sure to create an inclusive virtual classroom. When you go into that session, remember that that child looking at you from across the screen is missing that physical connection. So you have to bring it back virtually. Create that welcoming virtual space. Start each session with a greeting. Pose a question. Make sure that the session is still inclusive, not just you speaking at the parent, at the student, at the people in the home. Provide opportunities so that they can respond back to you. Continue to develop goals. Rewards can still include positive emails, positive certificates, positive items online that can still excite a student for being part of your session. Can still encourage the parent for being in that session with you. Create a procedure for each virtual feature of your classroom. Communicate with your expectations. Create your virtual norms before each session so that the parents and the student know what to expect every time you turn that camera on. Reach out to families at least once a week. Please don't wait. Typically, whether you checked in once a month or every few months, reach out once a week until they get comfortable with the new sessions and the new setting. And always reach out from a place of support. Know that now, if anything, they need you more than ever, clinicians. Reach out from a place of support and of patience until families and until students can get familiar with the technology and assistive technology answers. Offer sentence starters, utilizing virtual supports, provide extra video examples, and also remember one key aspect is record yourself reading, record your sessions so that parents have the opportunity to replay back those sessions and remember items that you shared, and they can continue being that learning coach in the home. Prompt your students to respond. Call on them so that they know, although this is not physical, virtually I can see you and I can still provide responses. Allow students to share their screens. It's important to include them in every aspect. Making distance learning successful. I'd like to share some strategies and some quick strategies with parents today, and also clinicians. As you work with families, please remember these strategies. Parents, set a distance learning routine for you and your child. Being a parent, of course, myself, I understand the challenges you face as a working parent or even parents in the home, trying to create these spaces for your child who is now more relaxed being at home and not having that routine of leaving every day to go to a school or a clinic setting. Create that space in the home. Children with autism or individuals with autism benefit from routine and structure. We know that is a strength. That is the strength. That routine, that structure, that plays back becomes set. This helps make the day predictable, and it can be very calming. So some ideas to implement your routine include: set a time to start school at home every day and stick to it to the best of your ability, just like you would a regular school setting. Do different subjects in the day in the same order, whether it be mathematics, whether you then take a break and then you come back and have a speech session, or you take a break and you come back and have a reading class, you take a break and come back for science. So please map out those sessions clearly. Set the same amount of time for each subject area and establish frequent breaks that occur at predictable intervals. Have a clock ready, have a timer ready to make sure that your student can predict when it's this time, we're taking a break. End the distance learning at the same time each day. And please remember to post a printed schedule in your workspace. It could be on the wall in the room that you've assigned. It could be on the fridge. It could be in your child's room. It could be somewhere in the living room where all family members see. But please make sure that there is some kind of a visual schedule. Establish a distraction-free space for learning. Choose a small room with a desk space or a small corner with space. Set up a place for parental supervision. Parents, even if you have someone online like myself or any of your clinicians that are educating or providing sessions in that period, be somewhere in the vicinity that you are not distracting your child, but that you can also step in when necessary. Don't allow music or toys or other devices in that space because it will be distracting. So maintain a strong, disciplined area. Have all necessary materials available to avoid all interruptions. And this is the time to really learn to manage sensory needs and behavior needs in order to plan ahead to be successful in those sessions. If your child needs a break, if they need to stop for a massage, if they need to stop and do jumping jacks, take a walk, if they need to stop to utilize tactile items, please take that 10 minutes or 5 minutes and stop and take a break and then reconvene again for the session. Also remember to create a visual schedule for distance learning by making sure to really support the transition. Transition is key. A challenging activity, as we know, for students and individuals with autism is transitioning. So right now, transitioning from no longer being in the school or being in the home when things are just different daily, they're not quite sure what to expect, this will be a challenge. So let's work together to minimize that challenge. And that visual schedule is key. It reduces anxiety. It will reduce some behaviors, and it will support staying on task. Take a picture of the learning environment, take a picture of the visual aids, use a screenshot if you choose to of apps and programs and items that you will plan to utilize in order to set up that schedule. I've placed a few pictures for you here just so you get a fair idea of the various forms of a visual schedule you can use at home and you can develop. Any of these can take you 30 minutes to an hour to create. If you're not quite sure how to, reach out, let me know, to show you how to utilize these visual schedules so you can have it available and ready and have your child check in with it every day. This is what's next, and these are great reminders. And for older students, you can now utilize your visual schedule on your phones, on your iPad. So bearing in mind, these are just a few fundamental and primary areas for you to be able to provide supports in the home. Please remember to use these with fidelity. And I'm going to stop quickly so I can take a few moments to answer some questions. And the first question here is, what support do we have for families with autism issues in Nigeria? So we're offering a lot of virtual supports, virtual therapy, teletherapy. We have multiple supports round the clock to provide supports for families, provide in-sessions, provide trainings. So we have multiple supports and multiple resources for evidence-based practices for your child, because we want to make sure that we support regression. We want to make sure that your child does not regress in this period up until things going back into the physical setting. Okay, another question here is, how can we create awareness and rise above stigmatization placed on autism in our communities? Well, this is a very good question. How can we create awareness? Really creating awareness on moments like this that GTB has set up, being able to support presentations, support events, speak out in your community, join those parent groups online. Really, this pandemic has caused everybody to unite online, where you don't have to travel around to physically drive and find a location. Speak to one another. But please, as always, I encourage you all to make sure that as you're building awareness, in order to remove stigmatization, let's think about evidence-based practices, research-based practices to support the community and support our individuals with autism and their families. Remove the stigma or remove the myths. And I believe a couple of years when I spoke a while back, it was really, let's dispel a lot of myths out there. So awareness and education is key. And with awareness and with the education that is key, we can get into each family's home and we can support you now. The beauty of the world of online is we now have access to you without you traveling back and forth. So we can continue providing you supports. Various settings. We have families that call at midnight because there's a behavior concern in the home. We have people around the clock. So parents, please be encouraged. Yes, there may not be school right now, or yes, there may not be clinics open right now, but clinicians are still available. And we will continue building awareness until we make sure that every family is reached and is touched, and we see differences. And I'm going to move on to the next question. What about autistic children in schools? Where do we get support and guidelines in identifying and handling? So right now, you know, I always say, again, person first, right? So children with autism in schools, my question would be, is the school open? Is the school reopening? And have they set up a safe safe guidelines in order for safety for all students. And if the school is open or if the school is not open, we can access, and we have a lot of our resources, and GTBank has set up the directory and information here so you can access us and we can provide you those supports and guidelines. There are multiple people on the panel today, and all the wonderful and exciting people here that have information. We have information to share with you to continue providing you with supports and guidelines. And when I say guidelines, I always remind families, again, with practicality, the how-to. From the moment you wake up in the morning to the moment you go to bed at the end of the day, how can I support my child? Or now that my child is not able to go out into the community to socialize, how can I bring socialization virtually? And families and clinicians, I really want to encourage. I know through this pandemic, what I have seen in a lot of the presentations and trainings I'm providing, somehow people are now moving into one-on-ones. Please remember, socialization is still key. Communication is still key. So when you're offering your services and we have the ability to have a second student in the room, a third student in the room for group sessions, please provide that opportunity. There are moments to have a goal so that there's individual skill sets being attained, but there are also moments to have goals for the group so that individuals can interact with one another, have opportunities to share with one another, and continue conversing and connecting with one another, although they're not able to now do this physically. And I'm not sure on my time here, but I'm going to try and get to another question. I have a question.
So your session was supposed to end at 12:30, but we have a 30-minute break. So please do feel free to keep on taking questions.
Okay, thank you.
You're welcome.
So I have another question here is, how do I find out if my child is autistic? So how do you find out if a child has autism? And this will begin with evaluation. I know when you've often heard early intervention is key. And as I always remind families, yes, early intervention is key. The sooner the better. When you feel something is wrong, as parents, you have that instinct. Or a teacher or somebody at school or in the community may have shared something seems off or a little different. But if that is the case and you want to have your child assessed, please make sure that the person assessing it has a credential, a license, and that you trust that source. And if you're not sure, reach out to us, and we also provide teletherapy and assessments virtually and also in person, depending again on making sure that there's that safety structure. But assessment is key. We have to begin by conducting a psychoeducational evaluation to diagnose. We have to make sure we consider the traits. We have to make sure that we're looking at all aspects. And also at this point, depending on the need, you'll be able to receive multiple assessments for a multidisciplinary report will be essential. We'll have various psychologists and therapists that can conduct assessments. And if this is the case, when you have various members working on an assessment, please ensure it is a multidisciplinary report so that all those involved in the assessment can see the whole child, and not breaking it apart in silos where you can be tapping and overlapping with your supports, but you're working in silos. Let's work together, clinicians, even in assessing. So once the assessment is conducted, the data will inform you and the data will let us know, is there a disability? And if there is, what type of disability? And when we know what type of disability, what area do we see challenges in? Is error in communication? Is it in socialization? Is it behavioral? Is it in sensory based? So there are multiple items that as clinicians we need to seek through assessments and gather data in order to provide you supports. Once the assessments are conducted, based on that data, then goals begin to be developed. A plan is then created. And please make sure that this plan isn't created once and then you move on. You have to revisit this plan consistently. Okay, and I'm looking at another question here. I have a question here. As such, it is even difficult to determine what the challenge is all about. He is hyperactive. And really at this time, although you may know what's happening in the home, if you feel your child is hyperactive or if you feel your child has ADHD, this is where, again, you'll need to reach out and have an assessment conducted. We can conduct an assessment even through virtual and teletherapy. Through the cameras, we can monitor, we can observe, and observation is key. Your input is essential because you are the parent and we trust your input. You are part of this team. By being able to monitor, by being able to really look at what is happening in the home, what time in the day do you see hyperactivity? Are there triggers? What areas do we need to assess in? What areas do we need goals in? But above all, what's the plan? What is the purpose? We need to make sure that the bigger goal is independence. For every individual with a cognitive disorder, we're looking at independence. So how is that hyperactivity impacting your child? Is it hyperactivity? They need to go outside, just shake it off, do some exercises, come back in, and they are prepared and ready to stay on task? Or is it hyperactivity that is disrupting them from their work? And the question with that then becomes, how can we channel through, provide replacement behaviors at the appropriate time, but also still ensure that you're not restricting your child so much so that they're not able to be themselves. They should have the ability to be themselves. And then just forgive me if I'm touching briefly on these questions. I'm trying to get through as much as I can. I have a question here. My son is 16 plus and having the challenge of how to communicate sex education to him. And I need a serious behavioral modification for him. So I would say the first step here for behavior modification is, who are you working with? Please reach out to, one of the our resources, our organizations, the multiple companies and supports we have here through the panels here, and be able to reach out to a behaviorist so we can provide support. Let's understand what is going on and be able to deliver sex education appropriately for the setting, for your child's age, and make sure that also we're also determining how, if there are any impacts, what the modifications need to be, how the implementation needs to take place in your home, how it needs to take place in the community, so that your child is learning what is appropriate. But also, again, as getting older, there are multiple questions. There are hormones and they're just adolescents. So these are conversations that we as clinicians need to make sure that as we train you as the parent, as a learning coach in the home, we're also supporting your son and delivering a strong program and delivering a program that we know that he is not only learning from, but can continue to grow for independence. So please reach out to one of us to be able to support you, to begin to have the conversations of the best way to tackle this communication or this specific question or need that you do have. There's another question here. I am an early years teacher in Nigeria. How can I get professional training and certification in the field of autism, whether in Nigeria or elsewhere, so as to better understand and help care for children with this challenge? So really is, again, as I shared with the beauty of online, the internet, there are multiple webinars, there are multiple training sessions taking place. Look at our companies, the panelists have multiple opportunities, both in Nigeria and outside of Nigeria, where you can be provided with education and training. There are multiple schools and universities that also offer specific certifications. And again, this brings me back to families. Please make sure that the clinicians you're working with are fully licensed and credentialed. And you can get those credentials from universities, from schools, from programs that can certify you, and make sure that they're accredited schools for the certification. and also continue to sign up online, search online, tap into our organizations and companies. There are multiple ones, especially through this panel. There's a lot of wonderful resources here to continue to access the resources, the webinars, and all the trainings that we do provide for clinicians. And if you are going for your autism credential, please make sure it's through an accredited university or an accredited program. Okay, so I think I will answer one more question, and before I wrap up. And the question here is, how can we help or support our kids with developmental disorders at home now that COVID-19 can't allow us to visit the specialist? So going back to my training and going back to the PowerPoint, it is really imperative, parents, that you understand in this pandemic, you have become the learning coach. You have become that clinician in the home, that educator in the home. So the good how, step one, will be to get involved in these webinars, the resources, reach out to the clinic so that we can help you develop a plan. We need to know where your child left off at school. We need to know what the IEP stated. If there was an IEP, we can still continue to develop an educational plan. But please know, as parents, you must now be prepared to discipline yourselves at home, even if it's in increments of an hour or 2 hours or a 3-hour block. Please make sure you are setting aside a specific schedule. That is how you'll help your child in the home. Create those items that we would in a school. When you go into school, we create the morning greeting. We have that time where students can go outside and interact and just shake it off and be ready to come back into the classroom. We then sit down and teach reading for an hour, and we break those reading sessions up. We teach mathematics for an hour. We teach various subjects, and then we separate that with socialization, making sure you can keep your child engaged. That is what you are now going to be doing at home during this COVID-19 pandemic. And it is not a far stretch. It's something you're already doing, but now is the time to maintain, build consistency. And if there are behavior problems, and I know a lot of families feel we cannot do this, we are not trained, this is where we come in. We will train you. We will continue to support you. One at a time, we can help you create a schedule for your home, but you also must be disciplined to really, let's talk openly and honestly about the challenges you will face in your home for your child, so that we can support research-based interventions and implementations in your home, so that you are being supported with research-based programs, and also being able to continue to see your child grow until whenever they can get back into the physical setting in school and you have avoided regression. Okay, so I'm going to stop there and let everybody enjoy your break. And I'm not sure if you still want me to stay online, but I will, I'm still here if you need me, but thank you so much. I've appreciated the opportunity as always. And please know that I'm here to support as well as everybody else on the panel.
Thank you. Thank you so much, Dr. Loretta Burns. That was such an amazing session. We went way over time, but that is fine because we had a 30-minute break. But I think people really appreciate the time that you've taken out to answer questions and address any issues that they might have with people in their lives or people they're taking care of. Once again, please save the questions for the Q&A tab and just go to the comment section to let us know where you're logging in from, what you do, how autism has affected you in your day-to-day life, why you do what you do, just anything. So we know who we're speaking to. We know who this is airing to. Hello to our 409 participants. Thank you so much for joining us again, this is something that means a lot to the bank, to GTBank. This is something that needs more people understanding it and more people learning about it and more people getting involved with it. So thank you again to our keynote speakers who have spoken, Dr. Andy Shih, who was amazing, Dr. Pamela Dixon, Dr. Loretta Burns. Thank you so, so much. If you have any questions, keep putting them down in the Q&A tab. If we don't get to them today, we'll get to them tomorrow, and we'll try and answer as many questions as possible. We have now an 8-minute break, and then we will start with our next 3 keynote speakers, Dr. Brooke Ingersoll, Dr. Lanre Duyile, Dr. Maleshwane Marco. But while we have this break, we're just going to have Dr. Pamela Dixon come back on to answer a few more questions, seeing as she didn't get to answer that much. So Dr. Pamela Dixon, if you want to join us, and if you have any questions for her, again, drop them in the Q&A tab. And yes, Dr. Pamela Dixon, over to you.
So I'm getting a message, my speaker's not working. Can you hear me?
Yes, we can hear you perfectly well. So we're just going to keep going and then answering questions, and we'll go on to the next keynote speaker.
Okay, so I see a question here. Someone would like to know, let's see, high functioning autism and how this relates to the spectrum concept. So I think the question is about how does high functioning autism relate to the spectrum, to the terminology. And some of this is just terminology. I think what people are, what we call now high functioning autism, we used to call Asperger's syndrome. And the reason that we call autism a spectrum is because, for one thing, all children or people with autism differ from one another and have relative strengths and weaknesses. And so you have people who are considered high functioning, meaning that they're verbal and have average, at least average IQ or cognitive functioning. Okay, looking for other questions. So there are questions about the getting access to the trainings that that I talked about. So specifically for the Caregiver Skills Training Program, the intention is for the program to be implemented in a system. So for example, in an educational system or in a mental health or medical system, so that it can ensure that it becomes part of regular offerings for families. This is also being done in partnership in some countries, in partnership with large NGOs and UNICEF. But the idea is that rather than it being implemented at, just in a center level, we want it to be implemented at a larger level to ensure that it has maximum reach. So what we do is try to get together. Usually what happens is that you can have, there's several smaller organizations interested in the program, and we try to get everyone coordinated and help to engage a government agency in an interest in having this become part of their system. And so this is a very individual processed by site or country. And so if you are someone who's interested in helping or interested in it being implemented at a country level, please email me and we can have a discussion about other people within your country that we know of that are already working towards this to get everybody working together. If you are interested in taking a look at the program, the e-learning version of the materials, I have put that in the chat in the Q&A box, and you can feel free to go and take a look. If this is something, those materials are in draft form and are at this moment only available in English. But if any site that decides that they want to adopt the program, the first step would be working to make sure that it gets translated and adapted. And and so that's something that that we have a team of people that work towards helping with all the aspects of implementation of the program. So feel free to send me an email, which I put in my email address in the chat.
Hi, Dr. Dixon. Yes. So maybe we'll take one more question, and then I can then introduce the next speaker, as we have about 2 more minutes.
Okay. I'm scrolling.
Okay.
To see, to get to a question. Let's see.
Okay.
Actually, I would like to just take the time to kind of look through each of them individually and respond with in typed form. Unless there's one that you've identified that you want me to focus on.
No, we're just kind of going to leave that to you. But if you do want to take your time and do that, then by all means, of course. Of course. Thank you so much, Dr. Dixon. So again, thank you so much, everybody, for logging on. This is a course that, again, means a lot to the bank. We have our 400 participants on Zoom and our 400 plus participants on YouTube. So thank you so much, everyone. This is clearly something that means a lot to a lot of people. So we're going to move on to our next 3 keynote speakers for the day, Dr. Brooke Ingersoll, who is a psychologist and director at MSU Autism Lab in the USA. And she will be talking about using telehealth to deliver parent training. We'll do that for 20 minutes. We'll listen to Dr. Ingersoll for 20 minutes, and then we will quickly move over to Dr. Lanre Duyile, who is a board-certified behavior analyst in Canada, and he will be talking about addressing behavioral difficulties in children and adults. And then we will then shuffle over again at 1:40 to Maleshwane Mauko. Again, I hope I'm saying that properly. Who is a board-certified behavior analyst in South Africa, and she will be speaking on managing eating difficulties with autism. If these are topics that interest you, please drop comments in the comment section. Let's see what you're interested in listening to, what presentations you've enjoyed, which ones you're excited about watching. And we're going to move on to Dr. Brooke Ingersoll, who is going to be speaking till 1:20. And yes, over to you, Dr. Brooke Ingersoll.
Thank you so much for having me here to present. And this is a really exciting experience and opportunity. I am a clinical psychologist and a board certified behavior analyst, and my work has been focused on developing parent training or parent mediated interventions for families of children with ASD. And I'm particularly interested in ways that we can use technology to increase families' access to this type of therapy. And so this talk will be quite relevant based on some of the work that was presented this morning. And I'm really excited to share this work with you. So I'm going to go ahead and begin. Okay. All right. So as I mentioned, I've been very interested in the ability of different types of technology to try to increase access to services. So my very brief overview of what we're going to be talking about today is the use of parent-mediated intervention or parent training to deliver, to help parents increase their children's skills, as well as telehealth coaching models. And then I'm going to spend a little bit of time talking about how one would actually deliver a parent-mediated intervention over telehealth. So some of this information is quite familiar to you all because you've already heard some great talks talking about parent training or parent-mediated intervention. But when we're talking about this particular approach to intervention, we're really talking about a systematic instruction in strategies that help parents accomplish specific goals or outcomes for their child. So parent-mediated interventions for children with ASD typically focus on improving the parent-child interaction, teaching the child specific developmental skills such as social communication skills, communication, play, language, as well as skills like self-care skills, toileting skills, dressing skills, and then finally focusing on helping parents manage challenging behaviors. And when we think about this type of intervention approach, we see that it's considered an essential part of a comprehensive intervention for children with ASD. But it can also be considered a primary intervention strategy, particularly for children who may be very young or maybe are showing early symptoms of ASD but don't have a formal diagnosis. And sometimes it may be the only approach that we can use in certain areas that don't have more comprehensive intervention services available. Now, when we think about parent-mediated intervention, it's a shift away from an expert delivery model where the provider is the expert who comes in and works with a child to a partnership model where there's a shared level of expertise. The therapist or coach has expertise in the intervention, and the parent and the family have expertise in the child. And the goal of parent-mediated intervention is to really help parents develop skills and the confidence to be able to change their behavior to help their child achieve specific outcomes. Which means that the roles of the provider and parent are somewhat different from a more traditional child-focused program. With parent-mediated intervention, the provider or therapist coach's role is to really collaborate with the parent to develop goals for the child and then help the parent learn the strategies to be able to use, to be able to achieve those goals. And then the parent's role is really to carry out those strategies during their daily routines and interactions with their child in order to help their child develop. So when we look at the intervention on parent-mediated intervention for children with ASD, we see benefits for both the child and the family. So in terms of child outcomes, we see improvements in social communication skills, adaptive skills such as self-care, and appropriate behavior. Another benefit is we see better generalization and maintenance of skills than in a more traditional child-focused intervention. And that's because the children are learning to use their skills with those individuals with whom they're expected to interact. So if their parents and family members are using the intervention strategies with the child is much more likely to use their skills in meaningful environments. And that helps them both generalize their skills as well as maintain their skills over time. And then it's also time and cost effective in that it takes less therapist time to achieve the same level of child outcome. Because the therapist may be spending 1 hour a week with the family, but then the family learns the strategies and then they can carry out those strategies throughout the child's day. So particularly in areas where access to more intensive services are challenge, this is a particularly effective approach for improving child outcomes. But we also see improvements in family outcomes. So families that have received parent training tend to experience greater self-efficacy and confidence in their ability to help their child. We see reductions in parenting stress and overall more positive family interactions. So there's some real benefits to using this approach, either along with a more comprehensive program or as an approach on its own. So now I'm going to switch over and talk a little bit about how can we do this using telehealth coaching, because most models for parent training are typically done either in a group setting where the parents come as a group and they're instructed as a group and then they go home and work their child, or an individual setting where the parent and child meet one-on-one with a therapist and the parent learns and practices. Those approaches require the family to be able to be close to the provider in order to actually participate. And currently with the current COVID epidemic, face-to-face interactions are really challenging. And so telehealth actually offers a really good approach for surmounting a number of those types of barriers. Because with telehealth, the parent can meet with the coach virtually, still learn the skills. And so they might be meeting with a coach who may not even be in their same town or their same vicinity. They may be able to get help even without having to travel. And particularly during COVID, this is very helpful. So what I thought I would talk about now is how we've taken a more traditional parent coaching model that's designed to be conducted one-on-one, where the coach meets with the family and the child and provides instruction, to talk a little bit about what this might look like with a telehealth delivery. So the first step, regardless of what you're doing, is to determine as the coach and as the family what strategies you're going to be using. And this will depend very much on what the child's needs are and what the family's needs are. So if the family has a specific behavioral challenge they're trying to deal with, for example, then the coach could help them select an evidence-based practice that can target that challenging behavior. If the child is needing to develop some types of social communication skills, the provider can work with the family to develop or to identify an evidence-based practice that we know would be effective for increasing social communication skills. So regardless of what way you're delivering telehealth therapy, the first step is to really decide what the child's needs are and then pick an evidence-based practice that's appropriate. And there are lots of different approaches out there. One approach is to use a manualized parent coaching program. And this is something that we do in our work. So Project Impact is an example of this. This is a manualized parent mediated or parent coaching program that targets social communication development in very young children with ASD. But there are also other types of approaches. There are individual evidence-based practices, and these are strategies that have evidence to suggest that they in and of themselves can target a wide range of skills. And for those of you who are not familiar, I would recommend you look at the Affirm modules. This is hosted at through the Frank Porter Graham Institute at University of North Carolina, and it's free. People can access it, and it has all sorts of information of evidence-based practices that providers could then use to help parents learn those techniques. And then there are also some self-directed online programs that are available that providers could actually go through with parents. Help is in Your Hands is based on ESDM, and Autism Navigator Interaction Project, or CERTS. For those of you who've heard those names before, both of these online programs provide a rich instruction, and then a coach could then work with the family to help them practice. So once an evidence-based practice is determined, the goal then is to provide coaching over the internet to help families achieve those goals. So the goals of coaching are to teach the parent new ways to interact with their child, to recognize the parent's strength and effort, provide them support, to provide opportunities for the parent to practice the strategy and receive feedback, to jointly identify and problem solve barriers. And then ultimately the goal is to increase the parent's independence of using the strategies during daily activities. And so the next steps I'm going to talk about are the typical steps we would use in a coaching session that would be done live, but modified for telehealth delivery. So the first thing you would want to do is check in, and as the coach is check in and set the session agenda. And this is an example of what this might look like on Zoom. We have our coach here and we have our family here. So the coach checks in, sees how things have gone, and then provides an overview of what the topic is going to be for that session. Typically, most parent-mediated interventions are multiple sessions, so maybe one session a week over 12 weeks, so the strategies typically build on each other. And so you would be checking in and saying what you were going to cover that day. And then you begin with reviewing the practice plan. A key component of parent-mediated intervention is for the parent to be able to practice those strategies at home with their child between sessions, and then report back to the provider and say how things went. And then they can work together to problem solve any challenges that came up while they were practicing without, on their own. Then the next step is to introduce the new technique. This is an example from our parent coaching program. Focus on Your Child is a strategy set that we teach, where we teach the parent how to follow their child's lead and imitate their child as a way of encouraging their child to socially engage with them and to be responsive to their child. So that might be the first strategy that you might teach. And when you do that, you're explaining the rationale to the parent, why they would engage in this particular technique that you're teaching. What goal does it have? The key elements. So specifically, what does it actually look like when you are following your child's lead? How could the parent actually follow their child's lead in an activity? And then explaining any individual steps that you might need to do for that particular technique. Then the next step is to demonstrate the technique. And this is typically done in face-to-face models. But when we're doing it over telehealth, what you're going to be doing is, rather than demonstrating live with the child because you're not present, you can do demonstration through video. So we share video models as an example of what the intervention strategy would look like. And these are short video clips, maybe 2 minutes long, that show the parent the specific skill we're expecting them to, or we're asking them to use with their child. Then the key piece of the program is to practice with feedback. So we have the parents actually practice with their child while they're receiving feedback from the coach. And again, here we have the mom and her son and her other child, and she's practicing using the strategies, and the coach is watching and observing and then providing both positive feedback about things she's doing that she could do, that she should keep doing, and then also some corrective feedback to help her change her behavior in slight ways to make the strategies more effective. After that, the idea is you want the parent to end feeling successful, and so you reflect, and then you develop a plan for practice. So you help the parent really think through, okay, now that you've practiced this strategy with my support, how can you actually do this at home on your own? And so we actually do screen shares, and we actually fill out a practice plan together, and then we email it to the parent for their own use at home. And the idea is that they practice that strategy at home, and then they report back the next session, and you have a discussion on how things went, and do some active problem solving. So I thought I would just end briefly with a video example of what this would look like. So this is an example of parent-mediated intervention called Project Impact that we've been delivering over telehealth. And here we have the mom and her child, and we have the coach down here who's checking in with her and providing feedback over the internet. And so what you're going to see here is first that sort of that check-in period and the review of the practice, and then we're going to see a little bit of what that active coaching period looks like.
Which is awesome. You say like numbers, the word numbers. Oh, I know. She said hat on and put a hat on, and then she.
Oops, sorry about that.
And she said hat, and then she walked over to a rocking horse, and she put it on a rocking horse and said hat on the rocking horse. Yeah, she's been pointing a lot too. Yeah. She just said it like 4 times. More bubble, more bubble, more. One, yes, one. More, good. More. I don't want bubble. That is awesome. Look at the point, and she looked right at you.
So in the video, you could actually see that the mom and daughter, the mom has already been taught a technique. She reviewed it with the coach, and then she was able to practice it with her daughter and get that active feedback. And she could then support her daughter in learning and communicating. So I wanted to thank my team that has worked on this work with me and see if there are any questions. Okay. So I'm not seeing any questions, which is fine. But if there are any questions that you have about telehealth or about parent coaching, I believe there's going to be a panel coming up soon that you will be able to ask some of those questions. But if there are any specific questions for me, again, I can just wait another minute or two and see if there's anything that comes up.
Hi, Dr. Ingersoll.
Yes.
If you check the Q&A tab, you should see a couple of questions. I can.
Some just popped. Oh, sorry, some just popped up. It is there. It just scrolled up there. Okay, thank you.
You're welcome.
So one of the questions is, how can we assist parents in poor communities in Nigeria? And there are a number of different options for using telehealth that way. A lot of it, of course, is somewhat dependent on internet access. But what I showed you was sort of what we would call synchronous telehealth, which does require some level of bandwidth to be able to have the family doing this. But we're seeing people do this type of coaching even with asynchronous, where people might be able to share, take a video of their family on a phone and share that in some way. And sometimes in areas where the technology isn't as fast, it might take longer to upload, but can send a video and then can follow up with the coach over the phone. So one of the challenges, of course, is the internet services. And I think that the other option that we have seen people do before is to make these types of online self-directed trainings offline. So you can make them as sort of a recorded video that the parent could watch offline. We've been doing a lot of self-directed. It's obviously not as good as if you have live coaching, but you could have the parent watch a video and then speak with the coach over the phone. One other question is, how many parents? Okay. So a question I saw here was, is parent coaching free? So it depends on how the service is offered. As part of our research study, we do provide it for free. Oftentimes providers will charge for parent coaching that's telehealth delivered, at least in the United States, as a clinical service. But different organizations can provide different types of sponsorship.
Thank you so much, Dr. Ingersoll. We have to move very quickly to Dr. Lanre Duyile, the next keynote speaker. Thank you so much for joining us. If there are any more questions for Dr. Ingersoll, please, again, put them in the Q&A tab and we'll be able to answer them at some point, possibly tomorrow. So I'm moving on to Dr. Lanre Duyile, who is speaking on addressing behavioral difficulties in children and adult. Dr. Lanre Duyile. Awesome. Thank you so much for joining us. We're really excited about your session, and I'm handing over to you.
Great. Just gonna quickly share my screen here. Okay, thank you so much for that introduction. I really appreciate it. And thank you to the professionals that have gone before me. I'm going to be talking about how we can address behavioral difficulties in children living with special needs, children and adults. At the end of this session, my goal is to be able to highlight why behaviors occur in general. I also want to be able to discuss some examples of behavioral difficulties and to discuss some ways of addressing behavioral difficulties, and I'll do that in a general sense. Once upon a time, people with autism were hidden and not to be seen. They're locked up, and I'm thinking that even these days you still have some of them. One of the presenters have talked about some stigma and social issues that are associated with people with developmental disabilities. We did not understand what autism is, and even till date, we still don't have understanding in some areas, especially in Africa. Some people still don't understand what it is, and some are thinking that maybe it has to do with uh, religion and demonization. The behaviors that are difficult for us to manage are the ones we refer to as behavioral difficulties. And today, I want to, get into why behaviors occur. Before we talk about behavioral interventions or addressing behavioral difficulties, I'd like us to call to mind that there are some individuals who have medical or biological considerations that are responsible for the behaviors that they're exhibiting. Another precondition that I would like to talk about before we go into behavioral intervention is the fact that diagnosis can play a role in behavioral difficulties. For example, if somebody has autism, we know that there are impairments in communication, so there will be difficulty in those areas. There will be impairment in social interaction and repetitive behavior. However, if somebody has a diagnosis of pica disorder, for example, the behaviors you'll be seeing that will be disturbing will be the fact that they'll be putting things into their mouth. They'll be eating things that are not edible. This presents a unique case of behavioral difficulty. In other situations, you may have an individual who is on a particular kind of medication, and the example I have here is the medication called risperidone. It is a second-generation antipsychotic medication, but it also helps to manage behaviors for some people. But this medication has a side effect of giving people dry mouth, so it makes them thirsty. So for a child who is taking this medication, or an adult for that matter, they may begin to seek water and seek juice and seek liquid so that their mouths can be watered up. And if they do this excessively, as can be seen in some of the cases of people on this medication, we say they have behavioral difficulties. But you may have the best behavior treatment in the world, but if that medication is still there and it's still causing the individual to be thirsty, we'll have issues. There's the issue of puberty, and I've seen some questions about how people can be trained or managed through that period in life. Physical structure is another issue that may be an issue with kids with developmental disabilities. Take, for example, a parent who is living in a small house with a child with autism. The child may want to pace back and forth. The child may want some physical activity, but because the house is small, he's not able to do that. So any little time that you open the door, the child runs out into the road, into the street, and it seems like they don't want to come back. So those are behaviors that happen that we regard as difficult, but they may be driven by things other than behavioral conditions. So in a general sense, in applied behavior analysis, when people are engaging in behaviors that are difficult, we say that they are doing it for certain reasons. And the general sense that we have is there are four reasons why behaviors occur, and we call those reasons behavior function. I'll go through those behavior functions one after the other. So the first one is attention, the second is escape, the third is tangible, and the fourth is sensory stimulation. I'll go through them step by step. So if somebody is engaging in the behavior for attention, what we will see is that the behavior is getting the individual something he or she wants. So the example I have here on the screen is Ngozi is watching TV alone and she's bored. So nobody is there with her, nobody is talking to her, nobody is interacting with her, and she induces herself to vomit. And immediately after she vomits, the parents come, the siblings come, they attend to her and they say, are you okay? And things like that. When that happens, Ngozi sees that, oh, I induced vomit or I threw up and people came to attend to me. So she may quickly learn that people pay attention when she engages in that behavior, and that behavior will continue to happen. In fact, I have a client that I'm dealing with that is currently doing that at the moment. If he's bored, you're sure he's going to induce himself to vomit, and people will attend at that time. The second behavior function I'd like to talk about is escape. A lot of times we do things because we want to escape a task or because we want to escape a condition that we consider to be aversive. In the example I have up on the screen, this is a situation where Greg is asked to take the dishes to the kitchen. So he lives in a house with his parents. Mom says, Greg, take the dishes to the sink, and he hits himself in the face. Why is that? We find that each time he does that, Mom asks his younger brother to then take the dishes. So the next time Greg will do the same and keep doing it on and on and on. So a lot of times people do things for escape reasons. The fourth one, the fourth behavior function I'd like to talk about, the third is tangible, the desire for access to items. So if I want something, for example, I want your pen, the typical way to get that is to ask. But for some kids with autism or developmental disabilities who are non-vocal, they may not be able to ask you, so they may grab it. We'll call that a behavioral difficulty. Another instance would be maybe they take it without asking you. That's a behavior difficulty that somebody may term as stealing. In some other instances, they may do several different kinds of behaviors just because they want access to something. The example I have here on the screen is Chichi is watching, asks Mom, I need to watch Sesame Street. Mom says no. Chichi then throws a tantrum, rolls on the floor, makes a lot of noise, and then Mom turns on favorite show. What Chichi learns from that interaction is that anytime I want something and Mom doesn't give it to me, I'll scream and yell and roll on the floor, and then Mom is going to give it to me. The final behavior function I'd like to talk about, the fourth one, is sensory stimulation, or otherwise referred to as automatic reinforcement. This is where the person enjoys and derives reinforcement from engaging in the behavior. These are behaviors that happen whether anyone is present or not. Example would be sexual behaviors, such as public masturbation, or even rocking, playing with things, in front of their faces and things like that. So how do we, these are functions, the reasons why behaviors occur. But before we can really get to the understanding of it as parents, as teachers, as people who are working with folks living with developmental disabilities, there's something called the ABC model that I'd like us to talk about. ABC, the A stands for antecedent, the B stands for behavior, and the C stands for consequence. As parents or teachers, you can begin to use this even right after this session. What you're going to do is just get a form or a paper and roll it up into 3 columns. One column is antecedent, the second column is behavior, and the third is consequence. An antecedent is anything that happened immediately before the problem behavior that you're describing, the problem behavior you're trying to deal with. And B stands for behavior. There's a specific behavior that you're looking to deal with. And consequence is what happened immediately after the behavior. Now, in a lot of cases, consequences are not what you think they are. Consequences are what the person engaging in behavior is experiencing. And they typically happen immediately after the behavior happens. So in the next slide, I'm going to show you an example of an ABC data sheet that you can create and use to develop, use it to inform your address for difficult behaviors. So here, you have one column, antecedent, behavior, consequence, and then I added the fourth column that helps you to try to figure out what the function of behavior is. So I'll start in the middle where you have the behavior. Bola bites herself and is crying. So you begin to wonder, why is Bola biting herself? What do I do now? But the way the ABC strategy is going to help you is that you ask yourself, what happened immediately before Bola bit herself? Then you write in, like I have here, mom is in Bola's room with her. Mom's phone rings and mom picks up the phone. What happened immediately after she picked up the phone and Bola started biting herself and crying? Mom hangs up the phone, and immediately mom hangs up the phone, you see Bola begin to wind down in her crying and she stops. What is the possible function of that behavior? The possible function here is attention. Bola does not want mom on the phone. She wants mom to spend all her time with her. So now you know that the function of that behavior, the reason for that behavior is attention. Number two, Bola starts crying and hits herself in the head. That's a difficult behavior. So your question will be, what happened immediately before that? Bola is watching TV, then mom calls him to come and eat. Coming to eat is a fun thing, you would assume, but Bola starts to cry and hit herself. So what did mom do? Mom tells Bola, okay, it's okay, you don't have to come now. Then Bola stops crying. The function of that behavior is escape. Bola has been able to successfully escape going to eat. So this is how we use the antecedent behavior and consequence model to try to figure out or inform ourselves of what the possible function of a behavior is. I'll quickly go on to the next slide. Now, once you do the ABC data and you have an idea of what may be the function, in behavior analysis, what we try to do is further subject that to tests to see if we're right. So one of the tools that we generally use is the questions about behavior function that was developed by Timothy Vollmer and Johnny Mixon. This tool is a 25 question behavior checklist tool that we use, and you can see on the screen there all the questions 1 to 15 here and all the way to 25. We would ask the parents these questions, and once they finish the answer, we'll then summarize the result from this. Now I'll give you an example of what the summary looks like. For a client of mine that engages in self-injury, this is kind of like the representation that we got after completing the QABF. This was completed by 3 different staff. The orange, the black, and the blue represents the 3 different staff. You can see from this graph that this individual, Tolu, is engaging in self-injury in order to escape tasks, and especially when he needs something as well. So we can see from this graph what the issue is. Then we can go to the next step, which is developing an intervention. Last year, when I came to Nigeria for the autism conference, I was a guest there. I met a boy who parents said he has a diagnosis of dyslexia, and they said he can't read, he's not doing well in school, and they're considering pulling him out. So I said, okay, if he can't read, let me just write something simple. So on the paper I wrote, I am a girl. And another paper I wrote, I am a boy. And I told him to read it. He read it correctly. And I was wondering, oh, he can read something simple. So I gave him a third paper and I said, hey, can you write for me, I am a girl and I am a boy. And this is what he wrote. Somehow, in his processing of that information, he took out am and a, and he replaced it with the symbol that I don't know. It's not in the English alphabet, it's not in the Yoruba alphabet that he speaks, but this is what he produced. This boy can never pass any exam in school because the teachers will mark this wrong. But if we have an understanding of what his condition is, then maybe he shouldn't be writing tests. Maybe he should be doing vocal tests, oral tests, instead of treating him like a typical student. So there are some situations where the individual is not willingly doing what he is doing, the diagnosis may be driving the behavior. There may be a skill deficit. So having said that, what are some of the examples of behavioral difficulties that you may be dealing with? Some have impaired communication, public masturbation, self-injury, aggression towards others, property damage, fear, feeding difficulties, bedwetting, stereotypical behaviors, running away. The list goes on and on. So how do we address this? Now, if you think back to my ABC model, I talked about antecedents, I talked about the consequences. And in trying to do an intervention, one of the things that you may want to think about is I can divide my interventions into two. I'm going to have antecedent strategies, and then I'm going to have consequence strategies. Antecedent strategies mean you must plan to do things before the inappropriate behavior happens. So try to take time, prepare the environment, prepare your teaching, prepare your lessons, prepare the home in such a way that it is supportive of the individual who is typically presenting challenging behaviors. One of the things you do is teach communication. Imagine I want to drink water. I don't know how to say it. The water is not available. Then what do I do? Maybe if I slap myself in the head, my parent will come and ask me what's wrong with you. And by the time they take about 3 or 4 guesses, they will be able to know that I need water, and then I get water. So inadvertently, what has happened is that the parents have taught the child that anytime you need water, slap yourself in the head and somebody is going to help you. So communication is important to teach before the behavior begins to happen. You need to pair yourself as well positively with the individual. Don't let your child, your student, see you as somebody who is all about work, work, work. Do something positive as well. Balance work and fun. Conduct a reinforcer assessment. And what does that mean? Look in the individual's environment. What are the things he or she likes? If you find those things out, then you should restrict access to them and give them to that individual only when they have displayed the appropriate behavior you want to see. One of the speakers talked about using visual schedules. Visual schedules are schedules of the things that you want to do using pictures, for example. So if John is supposed to go to the Ikeja Mall, and after that, he's supposed to go to maybe he's supposed to go to his aunt's house. One of the ways you can create a visual schedule is have a picture of the Ikeja Mall, the store that he particularly likes to go. So have a picture of that. And after that, take a picture of his auntie that he needs to go and see and put them side by side. So you're going to say to him, for example, hey, John, you're going to go to Ikeja Mall. So you point to the Ikeja Mall picture. And then after that, you're going to go to auntie's place and point to the picture of the auntie. So if you're able to teach the child in such a way that he can associate the pictures to the events that are unfolding, then you're using visual schedules. There's really more to visual schedules than what I've just said, but that's an idea. Give the heads up for transitions. So for example, the child is at the Ikeja Mall, and the next thing we're going to do is go to auntie's house. You need to give the child the heads up because he may be enjoying the Ikeja Mall so much he doesn't want to leave. So by the time you say, let's go, he may throw a tantrum, he may make noise, he may roll on the floor, he may give you difficult behaviors. But if you say instead that, oh, we're going to go to auntie's house in 5 minutes, then you've prepared the child. There's transitions before the behavior happens. Do not ask for too much when you're working with people with special needs. Go slowly and then build on what you've done. Set rules and enforce them. You need to have rules in place so that the child is not just all over the place and without direction. Set the rules and please make sure that you follow the rules and enforce the rules that you've set. Reduce boredom for our folks. If I am bored, I'm going to start pressing my phone. If you are bored, you're going to start doing something. So people with special needs also, when they're bored, they look for something to do. And unfortunately, sometimes that something is something that you would consider to be inappropriate behaviors. And the next one is using the Premack principle. Premack principle just simply states that when an individual is engaging in one task more than the other, you use the the tasks that they like to engage in to get them to engage in the ones that they really don't like to engage in. So I'll give you an example. So let's assume that Tunde, your student or your client or your child does not like doing the dishes, but he likes watching TV. So you're going to say to him, for example, Tunde, you need to finish doing the dishes before you watch TV. So you set the watching TV that he likes to come at a later time after he's completed all the tasks. That's essentially what the PRIMAC principle is. Another thing that we need to consider is caregiver match. The caregiver has to match. If the caregiver does not understand behaviors, they're probably going to create more behaviors. If the peers of an individual are laughing at him and teasing him, more behaviors are going to happen. If there's too much noise in the environment and the individual is bothered by noise, then you have a problem. What are precursor behaviors? Precursor behaviors are behaviors that predict that an inappropriate behavior is about to happen. So let's say, for example, before I really get upset, before I start hitting myself, before I start banging my head, I bite my lower lip. So the moment you see me biting my lower lip, that's a precursor behavior. You need to do an intervention right there. Don't wait until the inappropriate behavior happens before you try to do an intervention. Task analysis is consistent with not asking an individual to do too much. Try to ask them to do something in bits and build up the momentum from there on. The next strategies I'd like to talk about will be consequence strategies. So in this case, the behavior has now happened. And the next thing we need to do is do an intervention based on the behavior that has happened. So after the behavior is consequence strategies. If you see a behavior that you like, give verbal praise to the individual. If you see a behavior that you like, give physical feedback, high fives, and give me a fist bump and doing things like that. Some individuals like social reinforcers, like, hey, let's go for a walk, or hey, let's go to the mall, or let's go get an ice cream. Silly reinforcers, some individuals, whatever reason, love helping to wash cars, for example. If that is the kind of reinforcer, I call them silly, but it may be fun for some individuals. So use that. Another example of the token economy system. What does token economy system means? It is a strategy that we use where an individual earns what we call generalized conditioned reinforcers. And what happens is you can have maybe a sticker or check marks that you can put on a data sheet that the child is able to see for himself or herself. So each time they do something right, you put a check mark. If they do something right, you put a check mark. And you can set the criteria such that if the child is able to collect maybe 10 check marks, then they can get an ice cream cone. Then they can get time on the iPad. Then they can maybe watch your favorite TV show or something like that. But token economy is such that you give the child something small each time they engage in some specific identified behaviors. And then at the end of an identified period, you exchange those check marks or the tokens that they've received for something that is much bigger. Contracts will work more with adults and even some kids. And what that means is you just agree with the child, this is what you've agreed to do. And at the end of this is what you're going to get. Differential reinforcement is another strategy, but I don't have time to get into that now. Timeout. How many of you use timeout at home? But timeout sometimes will not work if you don't do it right. For timeout is removing an individual from an environment that is reinforcing. So if the current environment is not reinforcing for the child, don't use timeout, because then that is not a timeout. That is just you trying to take a break instead of, teaching something positive. Again, I don't have time to go into that, but we can talk about it at a much different time. Extinction. Extinction is a strategy in behavior analysis that we use, but it's not what it's not the English meaning of extinction. Extinction is a strategy where you discontinue reinforcement of a behavior that you've previously been reinforcing. And what that means is that you're essentially ignoring a behavior. If you ignore that behavior, the behavior will temporarily increase because the individual is expecting the reinforcement to happen. But if you continue that ignoring and you do not reinforce the individual the way you've been reinforcing them before for an inappropriate behavior, then the behavior begins to go down. Extinction is a strategy that helps you reduce behavior. Timeout is a strategy that helps you to reduce behavior. Penalties is a strategy that helps you to reduce behaviors. Penalties will be when you lose something for engaging in a behavior that is inappropriate. Social stories, in fact, I'm not sure why I put it here, it should be part of antecedent strategies. It's where you look at a situation and create a story about that situation and introduce it to the child. So that is social stories. And you can, so let's say, for example, you're trying to take your child to the doctor's office or to the dentist's office, and the child does not like dentists because it's painful and all of that and aversive to them. What you're going to do is create a beautiful story about somebody who went to the dentist's office and had a nice time. And you can introduce the child's favorite character. Maybe you have Dora the Explorer going to the dentist's office. Create that kind of story, read it to the child. The child gets to understand that story and maybe looks forward to expecting to have the same kind of experience that Dora the Explorer had in the story that you have created. And I think that's it for me. I breezed through that very quickly. If you have any questions, I think, do I have time for questions?
Hi, Mr. Duyile. We actually do not have time for questions.
Okay, good.
But I'm so sorry about that. We actually went
It's
5
okay.
minutes over time, but everyone can still drop their questions, and you can respond in the question and answer tab, or we can answer those tomorrow, but all questions will get answered. So please keep on dropping all your comments in the section. If you have any other comments, keep on dropping your questions in the question section. And if you have any additional comments, please put that in the comment section. So we're going to move on. Thank you so much, Mr. Duyile. So we're going to move on to our next keynote speaker, Maleshwane Mauko. And we're going to have another 20 minutes, and then we'll just take a few questions after that, speaking on managing eating difficulties with autism. Thank you so much for joining us, and we look forward to your presentation. Handing over to you.
I'll go to the first slide. Hello, hi. Okay. I'm just setting up the screen. Good afternoon to everyone. I'm going to be talking about how we can manage eating issues with children with autism. And at the end of this webinar, I would really like for you to come up with understanding what some of the underlying issues are when you have your child who's refusing foods. I'd also like for you to be able to assess to know exactly what it is that your child is struggling with, what your child is struggling with. And I will also touch upon some practical strategies on increasing the variety of foods that your child eats.
Ms. Melko, I'm sorry to interject, but could you make the presentation full screen just so everyone can see it comfortably? Is that possible?
Okay. Yes, I think so. Slideshow. Is that okay?
Perfect. Thank you so much.
Thank you. Okay, so I just quickly. So I'll talk about some underlying issues on food refusal. I'd also give you some hints on some things that you can do in order to assess exactly what it is that your child is struggling with in terms of eating. And then I'll give you some practical strategies on how to address the eating issues. So who is a picky eater? Usually when we a lot of the clients that I will get who are supposed to be, who has picky eaters will eat less than 20 foods of very limited, maybe even 5 to 10 different foods. A lot of the kids will eat only white foods. They'll eat, over here in Botswana, we have papa, paleche, or which is like a cornmeal, white cornmeal, or rice, like just rice, plain white rice, or just plain chicken. And they'll just stick to a particular color of foods. Also, some of the kids that I will work with will have issues with food textures. They'll only eat certain textures, and things like bananas that are mushy, they won't eat. And then I also get those children who you put the food in front of them and they will not eat it. They just will not accept the food. Some of the children that I work with will also have some behavioral aspect to their eating, which is as soon as you present food, they'll cry, scream, or they'll gag off the food as soon as they put it in their mouth and throw up, or some of the children will tantrum. And a lot of them are not willing to try different foods. They're very rigid to how they eat. They will want to eat at a particular time in a particular plate, with a particular spoon. So most of the parents will have particular things, like specific things that they will use during the time that the child is during mealtime. So when we work with a lot of the children with autism with feeding issues, usually you would have, when I used to work in the US, and I still do some consulting in the US, it'll be the feeding clinic will have an ABA consultant. There will be a speech therapist there just to make sure that there are no underlying medical issues, to make sure that there's no issues with their swallowing, that the food that is not medically, that there's no medical need for them to there's no medical needs attached to their eating problems. There'll be an occupational therapist who will check to see what exactly it is, if it's the texture, or if there's any other thing that is happening internally with the child. And sometimes we will also have a specialist who will look at if there are allergies there that we might not know of. If there's any other medical issues that are attached to eating that particular food. And then we will have what we call paraprofessionals, and paraprofessionals are your frontline people who'll be working, behavior technicians who'll be working with the child during their procedure, during their whole program for the eating. So the first thing, right after we do the medical checkup, which is the initial thing, I know in Botswana, we sometimes will not have a nutritionist available, or a doctor who, a specialist available. So a primary care, right after the parent goes to a primary care physician, then they will come to us. And the first thing that we'll do is we'll do a behavior assessment. Now, the behavior assessment, we will look specifically, the first one will be the behavioral assessment, where you want to see if the eating is attached to a challenging behavior, to see if are they refusing food because of the what the past speaker just spoke about. Is it an attention thing? Is it a refusal? Does it have to do with any skill deficit that the child might have? And then once we've determined if that it's not attached to any of those things, then we will go into a direct assessment of the different foods that are presented to the child, which is to see if it's a food selectivity, if it's because of the food selecting the different foods that you have, or if it's a food refusal issue where they just don't want to eat. And then we will look at we'll assess if there's unsafe eating behaviors, such as will they pocket food in their mouth and keep it there for a long period of time? Is it a swallowing issue? How then are we then going to create a program surrounding that? And then the last thing is we want to see, we'll ask several questions to see if your child, sometimes you'll have a child who will eat something at home and not eat it at school, or they'll eat the full meal at school, then they go home and they cannot eat anything at home, any of the foods that you presented at home. So we try as much as possible to see if like it's a consistency or inconsistency issue with their pattern within their eating. And you try to involve the parents as much as possible when you're doing the eating program, so that parents will slowly, once they've mastered eating a particular food, a target food within the clinic, that they now can eat it at home, so that it's not a behavior where they're not able to generalize the things that you're doing within the clinic to home, because that's a really huge issue. So after we've done our assessment, then we'll look at the results, and we'll look at if it's a texture issue. Is it because something is mushy, like I said earlier on? Is it because something is mushy, or they don't like crunchy foods, or they don't like foods that are slimy? And then after that, we'll also look at if it's a visual issue. Sometimes some children, if you put the food on a plate and they're all mixing up, they don't like that. They don't like their food touching, or they just like a particular color, like I said before. And if you also look at if it's a smell issue. I know, like growing up, I had an issue with smells, like I couldn't eat onion, and my parents actually had to cook my food on the side. And the knife couldn't touch the onion, and I struggled a lot with eating onions in that way. And as soon as I could taste that it was in the food, I would projectile vomit because the smell was so intense, and I'd get a headache. So we try to see if it's any of those issues, or it's just the taste of the food. Do they like sweet things, or do they like bitter things? Then once we've done that, the first thing that we do at home for parents is we try to encourage them to change the environment. We call it antecedent manipulation. So we try to make sure that parents at home change around a couple of things around eating. So it's a whole package of like changing the environment, so that then food becomes an enjoyable activity, becomes pleasant. We don't like it when you force feed a child. It's very unpleasant for the child, and it's also very unpleasant for a parent to force feed a child. So we want to change. We usually want to change that environment when we start working with feeding issues, and then we try to choose a time when a child is calm and they're having fun. And I'll talk a little bit more about that in the next part, where I talk about some strategies. We try to also schedule meal times and food introductions once we start working at home. That's a little bit later, once the child has tried a couple of different foods within the clinic, and we now know that what foods they like and what foods they can accept. Then we move it to home, where we start to schedule meal times, and we do food introductions. A lot of our parents will leave a plate somewhere and kind of have children, we call it grazing, like pick something to eat every now and then. So once we really start introducing it at home, we try to limit that a lot, so that like eating is scheduled and it's within a routine. And we also try to make meal times less stressful, so that the child enjoys their eating times, and we remove all distractions. We try to make sure that the parent doesn't have the TV on, toys aren't nearby, and video games are not nearby. And also when we start working on antecedent manipulations. And remember, antecedent manipulations are all the things that you can do before you even start to have the feeding program. We try to provide choices. And I know it's really difficult. I know in Botswana it's really difficult because a lot of our parents, you get what's in front of you. There isn't that much choice. So for some parents, there's a lot of they'll bring all kinds of food and put it on the table. But whatever it is that you're having, that you have at home, you could present it as a choice. Would you like to eat the meat now, or would you like to eat it later? Would you like to eat the rice now, or would you like to eat it later? So whatever it is that you have at home, the little that you have, as a parent, we try to make sure that we can make it as practical as possible. And then we try to incorporate some visual schedules. One of the visual schedules that I can send and put into the presentation as we're sending them out is a food game. The food game is basically called, like, we taste testing, we call it. And you put tiny little different types of food on a plate, and you take a die, like dice, and you, just like you play with the one you play with snakes and ladders with, and you can throw it down, and then it'll show you what food to eat. So maybe strawberries will be on number 8, and then they can try out the strawberries. Or we have biltong, or dried meat, will be on number 4, and then they can then choose that. So it's a very nice and enjoyable activity, and that has worked out very successfully for a lot of our kids. So here are 3 strategies to try at home. For a lot of the kids that I work with, I use a mixture of those strategies. Sometimes I'll use, one pairing preferred food with non-preferred food, which is getting something that is the most favorite thing, and then introducing something that is completely new. That one I would actually start it off and use with a token system. And then there's desensitization, which is trying to get them to start to accept different foods more and more. And then there's food chaining, which is, desensitization, which is trying to vary the textures and of the different foods that they accept. And then food chaining, which is increasing the number of foods that they eat. So if you're doing preferred and non-preferred foods, one of the things that we'll do is I will select, get a list of all the foods that the child needs, that the child loves, and then choose a non-preferred food target food that we're going to work on increasing. And the way that we do it is that you get that food, you put it in front of them. One of my kids actually loves chicken nuggets, but will not eat fish sticks. But they like to dip the chicken nuggets in honey. So what we started to do is we started to present the chicken nuggets. They dip it in the honey, and then they'll eat it. And then we'll get the fish stick, and they'll dip it in the honey and eat it. And that worked out really, really successfully, because it's what we call pairing, taking one food and putting it with another food in order to condition that non-preferred food to become more palatable for them. And then once the child accepts the food, we have lots of reinforcement round about there. We get really, really happy, but we try not to use too much social reinforcement, because the actual act of eating and accepting different foods should be what is reinforcing, as opposed to an external reinforcer. So if you see that your child is just accepting them, just accepting the food, just say something like, very, 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 don't say anything too loud and make it too loud. But if they like the social reinforcement, you can make it very loud. So it's basically you as a parent, you are the expert of your child in terms of what they like and what they don't like. You can also try to include a token system when you're using the preferred and non-preferred food system. I sometimes will try to do it as natural as possible. A lot of the times I do it as natural as possible, but I will have that game, and the children will play that game. And a lot of the times they start to eat a little bit more faster. The next type of strategy would be desensitization. So like the other, like the last strategy, you make a list of favorite foods. And then you present these foods during times when they're having fun. So if they're on the ground, if they're on the floor and they're playing a particular a game, you start to present the preferred foods there. And then you also sneak in one of the foods that are not preferred. because now you know if it's a texture thing or if it's what type, if it's a texture thing or a smell thing, you want to choose something that's as close to what they like as possible. You have them explore that new food with the other foods that they like, that they touch already. And as they're continuing exploring that food, the other foods and this new food, you start to have them play with the food, feed a doll. You have them prepare food with you that they can touch the food, and then you'll start to take the target food that you're trying to get your child to start to accept, for it to touch different parts of their body. So you put it on their arm, and you play around, and then you start to put it on their face, and they play around with it, and then in a little bit, you can then start to have them take the food and put it to their lips. It's not an expectation that they actually swallow the food. The big thing is that they put it to their lips, and that's a huge step. And even just touching that food, that new food, is a huge step for them. So it takes a long time to increase the number of foods that our children eat. So after that, the expectation is the next expectation after putting it on the lips is to put it on the tongue. And they don't have to swallow it. They can then take it out. Once they're able to just put it and taste it on their tongue, then the next step will be for them to keep it in their tongue for 2 seconds, 3 seconds, or to even chew it and then swallow it. Now, remember, it takes about 50 presentations of one particular food. So if it's rice or jollof rice, then that child it'll take 50 times of presenting the particular food until they decide that they like it. If it's something that they don't like, it's okay. Then we move on to the next food, because even I have things that I like to eat, just like your child has things that they like to eat. So we always have to think that like they have their likes and dislikes. The whole purpose is to increase the number of foods that your child eats, not to force them into eating foods that they might not necessarily like, just like you like different foods. So then we don't, like I was saying earlier on, eating should be a pleasant thing. I love food, you love food, you have particular foods that you like. We should never try to make eating something where you're force feeding a child and they're throwing up. It's very, very unpleasant. It used to be done that way, but we found out that with positive reinforcement, you can get a child to accept more foods and eat more foods. Now, the last strategy is called food chaining. This strategy works on increasing the number of foods that your child eats. So how we started, it's 4 leveled. The first level is if you want to maintain and expand the number of foods that a child eats. So if they're only eating 5 to 6 foods, you work on the food chaining strategy to increase the number of foods, the number of tastes and textures that they're eating. The next level is if you want to work on the variety of taste. How you usually do it is you start off with one texture of food. So if it's crunchy food, you start off with a carrot. And then you start to vary the different types of crunchy foods. So they like a carrot, you start off with them eating a carrot, then you introduce something else that's crunchy. Maybe a pear that's not as ripe, that's a bit more crunchy, or an apple. And then you start to slowly increase those type of crunchy foods because you want to increase textured foods, or you want to increase foods with a particular smell. The level 3 is you maintain the taste, so you maintain the salty taste, but then you vary the textures. So you can start with one salty food, but then you can look for other foods that are salty but have a different texture. So it could be biltong, which is like the dried meat, but the biltong with some honey on it, or you could get like another texture, like nuts, like sweet nuts, for instance, or or you work with you maintain the taste of the saltiness or the sweetness, but then you vary the different textures. The last level is you vary the taste and then you vary the texture. So you do both of them combined. So it's A and A and B, and then eventually it's A, B, C. It's A and B, A and C, and then lastly it's A, B, C. So you vary your different textures and tastes and foods in a very systematic way. And all of this, you'll be taking data and seeing how it's going, if your child is accepting food or not. We always provide a sheet that helps you to see, okay, 3 presentations of it and they've accepted it. It means that they now can eat the food, or, you know, it's a lot of trials until you get to a level where they can do that. And then lastly, try to educate yourself, try to observe how your child is eating, what textures of foods that they like. Try to read as much as possible to find out about what research is out there. When you come to us, it's always nice. We'll give you some of the information that you can educate yourself on. But it's always good when you have some knowledge, so that it becomes a partnership for us to work with you, and you can then also customize everything to your needs and your child's needs. Talk about food experiences. When the child is eating, say, "Ooh, it's crunchy, it's salty," and if they make a funny face, say, "It's not nice, it's too salty." So then that's building up some level of communication into it, because then they can say, "No, I don't like it," instead of tantruming. Offer small, nutritious foods. Now, like a chicken nugget is this size, we chop it up into the smallest amount of, the smallest size, so that we can then make sure that, we can build up to a level where our children can eat the whole food. One of the things is involving them in food preparation. So we try to get our kids to be able to touch the food, to smell the food. As they are cutting it, they're touching it, and it's a sensory experience. And this also helps in increasing the amount of foods that your child eats. And remember, it's small steps. Every little bite leads you to a level where it's a meal. So be patient with yourself, please, and also be patient with your child. It takes a while, but it will get there. All right. Any questions? Hello?
Hi, Ms. Malco. So you should go to the Q&A tab and scroll straight to the bottom, and then you'll see questions relevant to your presentation, and then you can start taking those. And we can do that for about 5-10 minutes and just get a few questions and answers in, and any more questions we have, we can just save for tomorrow.
Okay. All right.
Thank you so much.
No worries. Okay, one of the questions here is on, are there some classes or types of food children on the spectrum shouldn't eat? It's all about if your child has a particular allergy or not when it comes to food, but research shows that there's no particular foods that are recommended for autism or not. The next one. How do I get a child that pockets food in their mouth to feed themselves? My nephew does not eat by himself, still is fed by parents. Food pocketing is something that a lot of the kids do. They'll just take the food and pocket it and put it in the side, and then eventually it's called rumination, and they'll start, ruminate, it's one of the behaviors that falls under rumination. Either they pocket it, they put it in the side of their mouth, or they will then vomit it out, chew it, and then swallow it again. It takes a lot. One of the things is to do maybe strategy 2, where you start to vary the different foods that the child eats. One of the kids I worked with used to like to eat sweet things and then bring them back up again and enjoy them again. So what we used to do is to give them little pieces of sweet things and then so that they constantly having something sweet in their mouth, and it kind of stopped the rumination. But we were also working with an occupational therapist on that. I can write up something for you to help you out with the steps that you can follow to try to reduce the rumination, but you would need to see a healthcare professional before you could even start with that, because sometimes it's something that's lacking in their diet. One of the questions is, in view of food additives and sugar contents increasing hyperactivity in children with ASD, how can we manage food and the subsequent reactions on the child? That one, in terms of like the additives and the sugar content, is for you to really read the food labels very well. Try to limit, try to eat a lot more, try to present healthier foods for your child. And you can use one of the strategies on the second strategy, I think, on the training one, where you're improving the variety of foods that your child eats, but try to stick to foods that don't have the additives and the sugar content. In Botswana, a lot of the parents here stick to a traditional diet. We eat, sorghum meal. I don't know if you know the sorghum meal. Sorghum is a cereal. They'll eat foods that are a lot more traditional, because it seems as if some of like the foods that that parents usually buy, that a lot of parents used to buy, are very sugary. So the parents are sticking to a traditional meals that are very low in sugar, fruits, vegetables. What do you do about a child that won't chew? She pockets. I think I answered that one like that before. I will put something into the slides so that then that can help with some of the steps of things that you can do. With all these strategies, it is a disadvantage to the low-income class. Is there a home or special hospital where autistic patients are being managed? I'm not that well versed in Nigeria and what is available there. But I think there were a couple of BCBAs who are presenting on autism, especially the former presenter. They might be able to help you with some strategies on how to increase eating. The biggest thing is you as a parent learning and trying to learn on how best you can address some of these issues with your child. Even in the US, where I consult right now, a lot of the program that is done, one of the top things is that it has to be, if it's done in the clinic or in a hospital, the parent comes also and has their sessions also. Because what happens with autism is that sometimes the things that they learn at the clinic, they don't transfer them to the home. So you really have to make sure that parent training or caregiver training is at the forefront of everything that we do. That's thank you to GTBank. My son is 8 years old and is still being force-fed. How can I achieve this, since though he does not cooperate even in his happy times? He has CP and adenoids, and okay. When it comes to force feed, like you said, he has CP, so maybe make sure that you do a medical checkup before you go on to the next level. With adenoids, try to see if you can incorporate a speech therapist, to make sure that the medical issues is cleared up. But a lot of the strategies that I spoke about earlier on will work in terms of increasing the eating. Force feeding will only create a situation where that time eating becomes very aversive. It becomes a time where a child really doesn't want to come. Try to do an assessment to see what the type of foods that your child eats, and then start to try to pair those foods with things that they like. Make it a fun activity. A lot of the times with kids who, a lot of the times with our kids, the only time that they get our full attention is when they're eating. So make it pleasant, because, and then also give them attention outside of the eating. That's why I was saying earlier on, when they're playing, sometimes incorporate the play with food. Whatever food that it is that it'll let you have, you can incorporate it with their play, so that food now starts to become something that is, you know, if they're playing and it's with a toy, food becomes a condition reinforcer for them. It becomes something that's pleasant, that they want to actually run to the table and eat. I think there was something about sugar, and I think I addressed it in terms of like just a healthy eating program, just trying to give your child as many healthy things as possible, limit sugar. If you're seeing that your child is having a problem with sugar, maybe you might need to limit it, because then, you know, your child's behavior is communication. That's all what I usually say. So if they are having, you know, a reaction with the sugar, maybe it's something that you shouldn't be presenting as much to your child.
Thank you so much. Thank you so much, Miss Malco. Unfortunately, we've run out of time and we've gone far over our 2 p.m. End of day mark. But thank you so much for joining us. I think I can speak for everybody when I say that was a very, very interesting and educational keynote. And we look forward to you joining us tomorrow. Thank you so much. Thank you so much for everyone who's joined us. Don't forget to go on the website, www.gtbank.com/autism2020 to download the conference brochure, see all the speakers we have had today and speakers we have for tomorrow, see their bios and their topics, what to expect. Just a brief breakdown. We're starting at 12 p.m. tomorrow. We're starting talking about cure versus acceptance of autism. That's at 12 p.m. and we have 4 panelists discussing that. Then at 12:40, we have another 4 panelists in the Parents Forum discussing preparing a child for independence and interdependence. Then we're going to take a short break, a short 10-minute break. And then at 1:40, we're going to go into a Q&A session with another 4 panelists for 40 minutes. And then at 2:20 to 3 p.m., we're going to go again with another 5 panelists for another Q&A session. So all your questions that we haven't managed to get answered today due to time constraints, we're going to take into tomorrow, and we're going to make sure that we try and answer every last question and everybody is as educated on the topic of autism as possible. Thank you so much for joining us. Invite your family and your friends. You can join on Zoom, you can join on YouTube. We've loved having everybody here, almost 1,000 viewers. And we'll see you all tomorrow. Thank you so much. Have a lovely day.